from. And so, oops, I'm sorry. And so you will see that I have a little bit about history in here. There's a little bit about tumor biology, of course, and the growth and histologic patterns, prognosis, how we diagnose, stage, and treat, and tumor associations and unusual presentations. I've made it such that there is a quiz, and I don't know that I can monitor the chat. I will try my very best, but if you can speak up, that's also perfectly fine for me. Okay, so here we go. So what's the definition of neuroblastoma? Is an embryonal tumor of the sympathetic nervous system and arises during fetal or early postnatal life from sympathetic cells derived from the neural crest. It is the most solid extracranial malignancy of childhood and the most common malignant tumor in infants, and so should be well recognized by those who are practicing pediatric pathology. And the incidence is 8.5 individuals per 1 million if you're less than 20 years of age. That's in the US, and greater than 650 persons newly diagnosed per year. The prevalence is 1 in 7,000 live births, and it's responsible for about 15% of pediatric cancer deaths. So yes, it's a rare tumor, but it is the most common in childhood, so one should be able to recognize it. 37% of these diseases will occur in, or this particular tumor rather, will occur in infants, and about 90% of them in these patients, they'll be less than 5 years of age. There are racial differences in tumor biology, and African Americans are more likely to have a high-risk disease with fatal outcomes. Black and Asian children have a slightly lower incidence than those that are white. And then when you look at the age range, as I mentioned, the majority of patients fall below the age of 5 per 1 million. But what is interesting to note is that as one ages, you do have a drop in the 5-year relative survival. So as I mentioned, that age range can be usually between birth to 6 years, but there is a median of about 18.8 months. And a common presenting finding is an abdominal mass, distension, and pain. And if you look over here in this table, you can see that less than 1 year of age, the majority of places that these lesions are occurring are in thoracic area, adrenal, and abdomen. But once you get over a certain age, you see that the majority of them began to sit in the adrenal and the around the adrenal gland and the abdomen, which is not an adrenal gland. So sometimes around lymph nodes, around the spinal cord, etc., around the spine and paraspinal nerve tissue. That's usually where you see them. So here's a little bit about the historic description. So what do these two images have in common? Anyone want to enter something in the chat or to say out loud? As I take a sip of my coffee. No? If anyone wants to answer, nope. I don't see anyone, and I know that we have rosettes. Very good. Thank you for adding that, Kirabel. There are rosettes in here, but do we have a name for these rosettes? That's the link. Absolutely correct. So these are Homerite rosettes. So what they have in description and in common is the description of their name. So this is Dr. James Homerite on the left, and these are Homerite rosettes. Thank you. So these are obviously why they have something in common is their name. And this gentleman over here is the one who actually described these rosettes. Back in 1910, he actually published his observations on about 12 cases of the tumor. And in that time, he was at Massachusetts General Hospital and an assistant professor, and he really made waves because his chair at the time did not believe that this tumor was of the nervous system, and he actually thought that it was made from hematopoietic cells. So it was a very, very challenging situation actually for him to make this description and to publish it. So I'll move along. So while he just recognized that there was a neural nature of the tumor, the authors of previous reports described 2 other patterns of spread at that time. William Pepper described massive hepatic infiltration associated with adrenal tumors without spread to bone in infants. And in 1907, Dr. Hutchinson reported orbital and skull metastases in older infants and children. And I'll show you these in a second. So let's look at the embryology and the tumor biology. All of these cells are coming from the neural crest, and they depending on where they end up, will provide us with different cell types. And obviously, the ones that are of most interest are those that are in the adrenal gland, or that will eventually form cells of the adrenal gland. But these tumors are also known to demonstrate these unique type of biologic behaviors, such as involution, spontaneous regression, maturation, and aggressive proliferation. Now, one other thing that I thought that I would share, because I think neuroblastoma has changed so much since the time of its original diagnosis and how we stage it now and its prognosis, that I think we should sort of pay attention to how things have evolved. So back in 1988, there was an international cooperative effort known as the International Neuroblastoma Risk Group, and actually derived commonly accepted criteria for the diagnosis, staging, and prognosis of these tumors. And in that, they developed the INRG staging system, risk classification system, and a response criteria to treatment. Fast forward to 1994, when the INPC committee was established, or International Neuroblastoma Pathology Committee was established, which standardized the terminology and morphologic criteria and established a prognostically significant, biologically relevant, and reproducible morphologic classification. And I hope that during this talk, I'll be able to show you all of these elements that are very, very important in helping guide patient treatment. In 2011, there were revisions and updates to imaging and staging. The INRG tumor stages changed slightly. And then in 2017, there were revision and updates to the response criteria including evaluation, this response evaluation criteria in solid tumors, or the RECIST trial, which really helped radiologists as well to sort of identify what factors in treated tumors demonstrates improvement. And then finally, in 2021, there have been updates to the INRG staging system that includes COG trial and outcomes data, which is very important because, we all talk about practicing evidence-based medicine, and here it is in action. So let's go first to the gross findings of neuroblastoma. And here you can see there are many, many faces of neuroblastoma. Here's one in a lovely yellow adrenal gland. You can see the adrenal gland under here, and then a very large tumor that looks a bit nodular and quite fleshy, sort of red tan to white in some areas, and clearly arising in and around the adrenal cortex and medulla, kind of obliterating the medulla. And here again, you can see another one that's quite hemorrhagic, and probably this patient would have presented with abdominal pain because of all of this necrosis and hemorrhage. And then finally, here's another one that's a fixed specimen, but also demonstrates quite a lot of necrosis and some calcifications. Probably it looks a bit gritty. When we think about criteria for classification, we always refer to that criteria that was created by the International Neuroblastoma Pathology Committee. The person whom I think of the most is Dr. Shimada, who used to work here at NCH with Dr. Newton. But Hiroki Shimada is the person that actually came up with one of the classifications. And then afterwards, everyone from the International Pathology Classification sort of came together and said, hey, we should make it more standardized. And here are those categories: the neuroblastoma, which is Schwannian stroma poor, the ganglion neuroblastoma intermixed, which is Schwannian stroma rich, ganglioneuroma, which is Schwannian stroma dominant, and ganglion neuroblastoma nodular, which is a composite of both Schwannian stroma rich and Schwannian stroma dominant and stroma poor. And we'll go through each one of those categories. So here first is neuroblastoma. So when we talk about neuroblastoma, we have different types. So first off is undifferentiated, which is Schwannian stroma poor. In those cases, the nuclei are identifiable. They vary in shape from rounded to slightly elongated. They have the salt and pepper chromatin, and you can see distinct nucleoli. You can see them here as I point them out. In the background, there's very little in the way of neuropil. This might look like neuropil, but it is actually blood or red blood cells. And so not consistent with neuropil in the background. And things, of course, that can mimic neuropil, as I just mentioned, blood, but coagulative necrosis, fibrin, or collagen fibrins. fibril, sorry. And then, of course, in these patients, they will have an elevated urinary vanillimandelic acid as well as homovanillic acid levels to help confirm the diagnosis of neuroblastoma. And we'll talk a bit about how to confirm that diagnosis very shortly. And so in the undifferentiated neuroblastoma, we typically are not finding any neuropil. They should be completely absent, but we'll find these neuroblastic cells in abundance. When we move to poorly differentiated, it's composed of these similar undifferentiated neuroblastic cells, but now we have neuropil in the background. And neuropil, I like to think of as cotton candy. You can see a picture of cotton candy over here, a thing from my childhood that I love to eat. But you can see that nice pink cotton candy neuropil sort of sitting in between here. So if you have a little more neuropil and that's recognizable, you swiftly move to that poorly differentiated category. However, most of these tumor cells in this lesion will appear undifferentiated, and less than or equal to 5% of those tumor cells will actually differentiate towards a ganglion cell. And if you're in doubt, neuropil can be positive for neuron-specific enolase and chromogranin, so you can stain them if you like. We try not to stain anything because sometimes it's much easier to just spend the time looking for neuropil and convince your colleagues of that, particularly if you get a little biopsy. And then, of course, you can always stain your neuroblastic cells if you're in doubt that it is truly a neuroblastoma. When we move next to the other category of neuroblastoma, it's called differentiating. This one, again, has abundant neuropil, but this time there's more than 5% or more of the tumor cells showing differentiation towards ganglion cells. So here you can start seeing differentiating neuroblasts. These are not true ganglion cells because they do not have the right cytoplasmic to nucleus ratio, but what you expect is that a much larger nucleus, or at least 3 to 5 times the size of, a much larger cytoplasm, at least 3 to 5 times the size of the cell. And then, of course, you need to have a prominent nucleolus for you to call it. So something like this would be considered a differentiating neuroblast because it doesn't have a prominent nucleolus, and the size of the cytoplasm to nucleus ratio is not quite right. In addition, you should have, as I mentioned, sort of this is called synchronous differentiation of the nucleus, where you have an enlarged eccentric nucleus with a vesicular chromatin pattern and usually a single prominent nucleolus. And as I mentioned, it should have a certain amount of cytoplasm, but the cytoplasm itself must be conspicuous eosinophilic or amphophilic cytoplasm. So if you notice that the neuroblasts in the background do not have much cytoplasm, though it is, some of them do have a little tail, that's kind of a bit basophilic. So nowhere near as eosinophilic as what we expect in the differentiating neuroblast. Moving on then to ganglioneuroblastoma intermixed. Essentially, you have a Schwannian stroma component here, and then you have the component in the middle here that I'm circling of neuroblastoma. That neuroblastoma component can be comprised of your undifferentiated neuroblasts, which I've shown you before, that have very high nuclear to cytoplasmic ratio, and it may also comprise differentiating neuroblasts and ganglion cells as well. And they look like scattered foci of neuroblastic cells. And of course, proportion matters, just as in the previous ones. So ganglioneuromatous component to neuroblastic foci should be greater than 50% of the total volume in microscopic fields, which takes time to evaluate. And last but not least, ganglioneuroblastoma nodular, which is composite. So on the outside here, this is a nice gross example, and here's the histologic correlate of a nodule that looks quite hemorrhagic and fleshy. And then on the outside, you see a whiter appearance of the tumor, which looks less hemorrhagic and also similarly fleshy, but is reminiscent of your Schwannian stroma. And here you can actually see that very well, a nice nodule comprised of your sort of poorly differentiated or undifferentiated cell type, your neuroblastic cell type. And on the outside, you have nice Schwannian stroma type component. And ganglioneuroblastoma nodular can have multiple appearances. It can be classical, where you have a sweet little nodule sitting within another, as I've just shown you, but they can be multiple. You can have a very large nodule that kind of almost occupies the entire size of your lesion. Of course, they can be single and multiple, and then you may have no nodule because you biopsy the primary site and you may miss that nodule. And then when you biopsy the metastatic site, guess what? It's not ganglioneuroma, but it's neuroblastoma. And in that, we would call that ganglioneuroblastoma nodular. Next, coming out of the, or getting more towards mature is ganglioneuroblastoma maturing. And you can really see these ganglion cells here set in the background of Schwannian stroma. They are mature and maturing. And how do you know that they're mature? Is that they have these satellite cells rimming them and they start having a larger prominent nucleolus, of course. And then no distinct nests of neuroblasts and no nests containing neuropil here. And then finally, ganglioneuroma mature, you can really see really nice ganglion cells wherein they have prominent nucleoli and surrounded by satellite cells. And the complete maturation requires the absence of a neuroblastomatous component. So if even you see a few areas that have neuroblastic elements, then you are beholden to call it ganglioneuroblastoma. So what kind of morphologies can we see in these tumors? I've shown you what is classic and what is most common, but here are three morphologies that are not so classic. Here is the trabecular morphology. You can see that it's forming nice little trabecules and even areas where you have your homoryte rosettes. Here is a rhabdoid morphology. This tumor looks rhabdoid in this area, but there were other areas that look more within, the expectation of neuroblastoma. And finally, they can be pleomorphic, particularly after treatment. They can look very, very ugly, but sometimes they can look ugly even before treatment, and this is one of those cases. So what other histologic features might one find and that are important? One is mitosis chiarexis index, for which I will spend some time on in a few minutes. But other things that may be seen not only histologically, but radiologically are calcifications. You can appreciate these calcifications here. Remember, I mentioned in terms of the embryology and development of these lesions, they can undergo regression. And how do they undergo regression? Well, they apoptose and die, and then they result in this dystrophic sort of calcifications that are present within the lesion. And that can be picked up over time on imaging. They may also incite a foreign body reaction. So you see here's lots of giant cells trying to engulf some calcified material. They can also have melanin pigment, and they may also have atypical mitotic figures. And so I showed you this classification. I'm going to hide Shimada's classification for now and just show you some important things here, that age, histology, and the MKI are what really make the difference. So how do we pass that out? Well, favorable histology versus unfavorable histology in the neuroblastoma category, as well as the other categories we will sort of talk about, and that's in this prognostic group over here. So you can see that favorable essentially is something that is differentiating or low and intermediate MKI tumor and in a patient who is less than 1.5 years of age. And similarly, a ganglioneuroblastoma intermix is considered favorable. Maturing or mature ganglioneuroma is considered favorable. Those that are unfavorable are those in young children or even the older ones that have a really high MKI, or they're just poorly differentiated depending on the age. And if you're over a certain age, any of those patterns or any MKI will just put you directly into that category of unfavorable. And then some of the ganglioneuroblastoma nodular is also considered unfavorable. So just keeping that in mind, then what are some of the prognostic factors? Well, of course, age of diagnosis matters then. If you're diagnosed younger than 1 year, you have a 90% 5-year survival, versus if you're over 10, you have a 66% survival. The reason for the discrepancy with these numbers here, because you see 5 to 9 is 52%, and as you age, you actually have a better outcome, is because of the admixture of other types that ganglioneuromatous tumors that may have a higher MKI will occur within this age group. And so those patients tend to have a poorer 5-year survival. Of course, the tumor histology, as I mentioned before, and then the site of the primary tumor. If you have an adrenal primary, it's usually associated with a more unfavorable prognosis and more often associated with MYC-N, which I will demonstrate to you in a few as well. And then the thoracic tumor patients also have fewer deaths, recurrences, and a lower incidence of MYC-N amplification. And patients may have regional lymph node involvement. And if they're older than 1 year old, that has a poorer connotation. So spontaneous regression, I will mention this just once because I think it is important for us to recognize that these tumors can regress spontaneously, and a patient may present to us like this, though uncommon. So it usually occurs in tumors with the following features: a near triploid number of chromosomes, no MYC amplification, no loss of chromosome 1p, lack of telomerase expression, expression of HRAS, and expression of neurotropin receptor, TRK, a nerve growth factor receptor. Essentially, it's a well-behaved tumor and doesn't have MYC-N amplification. Just remember that. Usually those are occurring in the babies and little ones less than a year of age, but they can have spontaneous regression. So let's move to something that's really important for all pathologists who are looking at these kinds of cases to know, which is the mitosis carrier index. It's defined as the number of tumor cells in mitosis and in the process of karyorrhexis. And this activity is assessed in relation to the cellularity of tumor with a denominator of 5,000 cells. And then we're looking for mitoses and karyorrhexis. So I'm just going to show you here. This is kind of eyeballing, but I'm going to show you here. On the left-hand side, you'll see a panel that has very high cellularity, but low mitotic rate. Here's a mitosis here, right? I'm not really sure. This is not quite clear, but maybe some of these might be mitoses, but this for sure is one. But overall, this kind of has a low gestalt of a mitotic rate. And the high cellularity is about 700 to 900 cells per high power field. So when you have a lesion like this, you can count about 5 to 6 high power fields and you will get a 5,000 cell denominator. However, when you have moderate cellularity, you will have to obviously increase the number of fields that you count. And similarly, with low cellularity, you increase the number of fields that you count. But again, these two fields, looking at them just at once at a glance, looks like there will be a low MKI just on the basis of very few mitotic figures or karyorrhexis. And so here is how you stratify it. If you have a low MKI, you're less than 2%, which is less than 100 mitoses and karyorrhexis per 5,000 cells counted. Intermediate MKI is anywhere between 2 and 4%, and high MKI with 4% or more. Rather, should be more than 4%. And so why is it even important? Well, there's a reproducible correlation between a high MKI and adverse clinical and biologic manifestation. And usually that has to do with MYC-N amplification. So what happens in MYC-N amplification, if it's amplified, they're usually undifferentiated or poorly differentiated, and that will obviously cause an increase in MKI. So what happens when you have MYC amplification? So when you have MYC amplification, this MYC actually turns on genes in your cell that causes proliferation to occur, and this is what ultimately results in the histologic expression of an undifferentiated or poorly differentiated neuroblastoma. However, when you don't have overexpression of MYC, then you don't make dimers that activate proliferation, but you actually make dimers like this MAX dimer that turns on differentiation genes, and therefore your proliferation genes are not turned on or is not as much affected, and as such you get more differentiation of your of your neuroblastic cells towards the direction of a ganglioneuroma, or at least ganglioneuroblastoma intermixed. And here is this somewhat in the same kind of thing. You can see that favorable neuroblastomas here are mostly triploid, and they have spontaneous regression. They'll regress on their own or spontaneous maturation. However, those that are going to behave bad will progress and they will have this 1p abnormality, 11q or other, and then of course those that have MYC-N. And note that it's about 20% of those patients that are going to behave aggressively and going to have this MYC-N amplification. So I keep hinting at the molecular alterations as being important, and yes, they most definitely are. So in sporadic neuroblastoma, there are really two categories of genetic change. There's an abnormal gain of whole chromosomes, and there are segmental alterations. And these alterations, these segmental alterations, are usually associated with an older age of diagnosis, an advanced stage, a higher risk of relapse, and a poorer outcome. And they can be divided also into those seen in familial neuroblastoma or those seen in sporadic neuroblastoma. So I'm just going to talk about a couple of these that are really important because now they have been included as part of the screening and testing that is needed in neuroblastoma. So for ALK, we see that in familial neuroblastoma about 1 to 2% of the time, but in sporadic neuroblastoma, we see it much more frequently in 6 to 12% of cases. And they're activating mutations, and ALK amplification occurs in association with MYC amplification. So of course, this predicts a poor outcome. FOX2B is a germline loss of function mutation and associated with Ondine's curse or congenital central hypoventilation syndrome, and may also be associated with Hirschsprung disease. And then germline deletion at 1p or 11q, the same deletions that can also be seen in sporadic neuroblastoma, but those also may predict a poorer outcome. So a hyperdiploid karyotype is a favorable prognosis. And if you have loss of heterozygosity, as I mentioned, 1p, 11q, as well as unbalanced gains of 17q, these all result in unfavorable prognoses, and they may be associated as well with the MYC amplification. And as I had mentioned, MYC amplification is just an unfavorable prognosis. Amplification simply means there's more than 10 copies per diploid genome. And then in the ALK activating mutations, as I had mentioned, they correlate with poor survival in high and intermediate risk patients. And so this shows the same thing this shows the same thing that I just mentioned, that as you, if you have these deletions, you will find that the 4-year event-free survival and overall survival are much lower. So I'm going to focus on some of the changes that have occurred within the recent past in diagnosis, staging, and prognosis, because although as pathologists, we are looking at the tumor and we are deciding what the histology is, much of the way that the patient is treated is dependent on the stage. And then, of course, what their response criteria is after they are treated. So how do we make that diagnosis? Well, first we have to do tissue sampling. That's where we come in, where you get the biopsy or the surgical resection, depending on how the patient is, how they decide to treat the patient. And that primary diagnosis, tumor or metastasis, we'll get a surgical resection where indicated and an incisional biopsy, sometimes greater than 1 centimeter cube. And then we can also get tissue cores. Sometimes we get, I've gotten 30 tissue cores, 20 to 30 millimeters in length with a 16-gauge needle. And typically we do intraoperative touch preps to kind of make sure that they're okay. In addition, patients will undergo bilateral bone marrow biopsies and clot sections. So the minimum criteria is that diagnosis from your tumor tissue with or without IHC or electron microscopy, or a bone marrow aspirate or trephine that has tumor cells, because sometimes it's hard to biopsy the main lesion, and elevated levels of urinary catecholamines. So you have to have a bone marrow plus urinary catecholamines or a tissue biopsy. And we have done this before many times, on-site assessment, kind of establish whether there's a lot of diagnostic tissue. So you can see here, these touch preps have a lot of cells, and there was a lot of cellularity here. But of course, here's a frozen section of one of the pieces of tissue, and it just looks like necrosis. So this also happens where you come and you get 30 cores, but of the 30 cores, maybe 5 have viable tumor and all the rest are necrotic. And there are a lot of tissue requirements for the COG trials that I'll touch base on in a bit. Well, right here, actually. So once we work with the specimen, one of the things that we typically do are create touch preparations. In the past, we used to put them in sterile culture media, and then we still snap freeze, but we don't usually use the culture media anymore because we can get all of these things, the MYC, the triploidy and stuff like that. Some of them we can get off of fish. The rest of it, we truly just freeze the piece of tissue and we can get the DNA ploidy. But all of the others, this targeted oncology microarray analysis that we perform, we do it off of FFPE. Similarly, the MICAN amplification we do by FISH, and ALK amplification we do by FISH. And then we have a full panel that we also do by FISH. I put in these costs because they're not cheap. They're quite expensive in order to do. And since I am from originally a Caribbean country and I look at US dollars and multiply them by 7, I can only imagine that it is very expensive for most patients to afford. In order to make the diagnosis, of course, you also need imaging, and that includes the CT and MRI. You also do an MIBG, and if the patient has non-MIBG avid disease, they do an FDG PET. Oh wow, that's a big gap, Johan. And so clinical staging evaluation, 70% of patients already have metastatic disease at diagnosis. So this MIBG scan, of course, is going to help you help the clinician that's taking care of the patient identify what's going on. And many of them will be MIBG avid because they are rapidly replicating. And if they're not, then that's when they will go to FDG PET. So now I'm going to move on a little bit to the staging system. The original staging system is, as you see here, with this cute little kiddo and the locations that are involved. However, while this was pretty good at the time, it has been realized that it was better to consolidate some of these staging systems. So there are 4 staging systems, 4 stages now. L1, which is essentially localized tumor, not involving any of the other structures. So basically localized to the adrenal gland. L2 is localized to the adrenal gland, but may also be, local regional tumor with presence of one or more one of these image-defined risk factors. So essentially, it may be involving an adjacent lymph node or something like that. And then M is distant metastatic disease, except stage MS tumor. And then, of course, MS is that M special that used to be called 4S in the past. That's metastatic disease in children younger than 18 months with metastasis confined to skin, liver, and or bone marrow. And these patients in the MS category tend to do very well unless they are really far gone or moribund, but they tend to do fairly well. And then I'm going to swing into the risk groups. So the risk groups were also used to kind of identify those patients using those staging groups, the age, the histology. Remember, we did all of these things. And then, of course, the MICAN, as I mentioned, the genetics is very important. Then using this information, risk groups were determined using over 8,000 patients with neuroblastoma from a variety of trials. And that's what this international neuroblastoma group actually came up with for pre-treatment classification. However, the most recent neuroblastoma risk classification is here, and this isn't. I'm just putting it up here so you can see it. But as you can see, it involves all of the things that I mentioned: the stage, the MIC amplification, the age, all of your pathology features. If you think it's favorable versus unfavorable histology. Things like your DNA ploidy and your chromosomal aberrations. And then you take all of that into consideration and you put them into a risk group. Why is it important to put them into a risk group? Well, that sort of predicts their overall survival and event-free survival. If they're in the low risk group, then of course their 5-year event-free survival and overall survival is greater than 90%. That drops in the intermediate group and it's even further fall or smaller percentage in the patients that are high risk. So this is why it's important for these risk groups. And the risk groups now, because they include all of this additional information and have the abbreviated clinical stage, really makes a difference for treating these patients. Sorry, I already went through that. And then here is how we treat based on their classification. So if you were in the low risk group, a lot of these kids are going to get surgical resection and observation. However, if you're in an intermediate risk group, you get chemotherapy, and then you may go to surveillance, or you may have to have additional chemo and surgery if you have more than a partial response or marrow involvement. And then finally, the high risk groups, sorry, the high-risk groups, essentially, they undergo the full consolidation period, and then may have to do continuation therapy if there's disease progression. So it really matters what you diagnose and how quickly you send your cytogenetics in order to be able to help the clinician plan for that oncologist rather plan for how they will treat this patient. So how about trying to figure it out from the back end? I mean, screening is a great idea if you could use it. However, our current data don't really support screening of neuroblastoma in this population. And there have been many studies in North America and in Japan, actually, that have demonstrated that it is not worth trying to screen for these patients, and there was no real reduction in the incidence of advanced stage neuroblastoma and no reduction in the overall mortality, unfortunately. Suffice it to say, these are older studies that were done, in the 80s, and one at least was done in the 70s. So perhaps there may be some difference now where we have better imaging facilities, but I still think the stance from the neuroblastoma community is that screening is not really going to be helpful at this time. However, if you have a patient who has neuroblastoma predisposition genes, like those that I had mentioned, ALK and FOX2B, and HRAS, those are the ones that you really want to pay attention to, because those patients may actually develop your neuroblastoma. They're going to develop things like leukemia, and they may have other issues that you want to monitor. And I'm moving slowly or quickly into the next area is really just the future directions. So I've told you a lot about the diagnosis, how to make the diagnosis histologically, the staging, the prognosis, and the treatment that is currently used. But now, what about future directions? Because not every patient with any of that, they can have all of those things happen to them. The diagnosis is made perfectly, the staging is done correctly, and the treatment is perfect. And unfortunately, regardless of that, they can still relapse. So what else is there out there for those patients who have relapse or who have other diseases? Well, not other diseases, but other progression of their disease. You can have patients that undergo immunotherapy. And so I think, some of the states in the Midwest actually do have this anti-GD2 monoclonal antibody. And in US and European trials have shown to have success post-consolidation. So the patient would have already been high risk, undergone consolidative therapy, and now have this anti-GD2 monoclonal antibody. Then there's, I cannot pronounce this, eflornithine, DFMO drug, which also is used in the high-risk population for continuation therapy and has had superior outcomes in comparison to controls, which is basically no drug. And then patients who have ALK amplification, the bonus to them is that there are targeted agents for ALK inhibition. So that might be a useful avenue. However, I do know that ALK inhibition does result in resistance. So, development of drugs that will not result in resistance is always a problem. And then finally, tumor mutation burden. Cases that have a higher tumor mutation burden are also associated with many inferior outcomes. And just for the last few minutes, I'm going to go through a couple unusual presentations, because I think these are really, I think for the pathologist, the diagnosis is easy, but they're really interesting to sort of see, because you very infrequently see them, and you need to put some of the clinical information together in order to make it make sense. So the first of which is Hutchinson syndrome, which is metastasis of the neuroblastoma to the orbit. And here you can see clearly an orbital lesion that is sort of pushing resulting in proptosis. Because of the presence of this lesion. And these patients present with periorbital ecchymosis and proptosis, also known as raccoon eyes, and a subset may obviously develop visual loss and blindness. So these patients usually require prompt initiation of chemotherapy, sometimes even radiation. And here you can see a patient with raccoon eyes and has a lesion in the adrenal gland, as well as lesions behind both eyes. Another of the very interesting associations is opsoclonus myoclonus ataxia, and it's seen in a very small proportion of patients who have neuroblastoma, and in only half of those patients do they find a primary tumor. I've seen this only once in my life. And it was very interesting because nobody could figure out what on earth was happening with this poor child. What the patient presented with was a combination of rapid eye movements, jerking limb movements, and ataxia. And of course, with these findings, most often the neurologic team is going to come in and say, oh, this patient probably has epilepsy. Let's scan the brain, and we find nothing. And then looking at the CT, they may find a lesion in or around the eye or in or around the cerebellum. And so it's hypothesized that this results from anti-neuroblastic antibodies that cross-react with host neural cells, particularly in the cerebellum. It does have a favorable outcome, but you have to identify that the tumor is there. And then it's often associated with favorable biologic and clinical risk factors, but there may be long-term motor and cognitive impairment for as long as the disease goes unchecked. So if you cannot find a primary, it becomes very, very challenging for these patients because they basically are shooting off these anti-neuroblastoma antibodies that are cross-reacting with the cerebellum, resulting in this cerebellar type clinical presentation. The next is stage 4S, which is Pepper syndrome. It usually occurs in patients less than 18 months. They usually present with discrete primary adrenal tumors that are often completely calcified. They may have hepatomegaly that has a diffuse liver involvement, and they may have a subcutaneous tumor-filled nodules known as blueberries, which I wouldn't really like to associate, but pathologists love to associate with food. Bone marrow infiltration of less than 10% without cortical bone metastases. And the natural history is that these tumors and their metastases often spontaneously resolve without systemic or local treatment, and is associated with super high morbidity because of liver involvement. And so here you can see a baby with multiple liver lesions here on the imaging, and then these blueberry type lesions all over his baby little body. Next up is Horner syndrome, which is characterized by combined findings of ptosis, meiosis, and anhidrosis. It's a thoracic tumor, which, the classic thoracic tumor, which impinges on your cervical or upper thoracic sympathetic chain and results in these three classic clinical presentation. Finally, dumbbell tumor or cord compression. It can present, I've seen this once as well, with an acute spinal cord compression. And so the tumor actually completely presses on that spinal cord and needs to be radiated, usually occurring in infants and toddlers who are very young. And the patient that I saw this happen in was a patient who essentially came in, and mom had said he used to walk, or he was walking, and then all of a sudden he doesn't want to walk anymore. He wants to be carried. And so once we did the imaging, then it was quite obvious that there was a tumor here compressing, and he underwent biopsy and then radiation once the diagnosis was made to alleviate the spinal cord compression. So I have a few quick notes on writing up the case and things to include. I do include the CAP checklist because we use the CAP checklist a lot. And so things that we should include in our biopsy write-up, of course, includes age, the histologic type, the degree of differentiation, the MKI, and of course, whether the histopathology is favorable versus unfavorable. And I will say that you should note here that it says favorable histology as sampled. And the only reason I say that is because of course, we get a needle biopsy and we do not necessarily see what's in the entire tumor, and something else might be lurking in there that we do not have that we will not be privy to on the biopsy. So nowadays, I think a lot of people are writing favorable histopathology as sampled, or in your comment, you put something like in this material or in the material examined. And that's how I've always been taught to write it up. And so something like this would be an example of neuroblastoma polydifferentiated MKI high with unfavorable histopathology as sampled. When you do the resection, you do the same things as the biopsy. Of course, if there's treatment, most people will call this neuroblastic tumor and then say, see comment. And in the comment, you describe what kinds of neuroblastic lesion you have. If it still looks undifferentiated or polydifferentiated, that's the place to put it, so that they are aware that this lesion didn't look like anything happened to it. They also want to know the completeness of the excision if possible, unless it comes in fragmented, which sometimes does happen when these adrenal glands come out very friable. And of course, the CAP template is helpful, but not necessary. I think in the US, we are moving more and more towards using CAP templates for everything, which is fine to kind of make sure that you include all of the important things that are prognostic and for treatment purposes, but it's not really always necessary in every case. I like to use it because it's very helpful to make sure that my residents and my fellows know what we're looking for when we're looking for it. And it's also very useful to help you when you're grossing. So here's an example: neuroblastoma schwanniangioma core, polydifferentiated with a low MKI and favorable histology. And I just say tumor completely excised. Usually I'll put in my comment what the margins are if they are able to be assessed. So I have a quiz, and I don't know if we have time for a quiz. It is 7:53 my time, which means that we have 7 minutes left. Do you think we have time for a quiz? I promise it's not painful. If you want, I'll just fast forward through it. So, few questions. What is the frequency with which NMIC amplification is seen in neuroblastoma? Is it A 50%, B 90%, C 20%, and D 5%? I should start like Jeopardy and go. You can feel free to enter it in the chat. Excellent. C is the answer. Thank you, Johan. Next up, what syndrome does this baby have? Osgood-Schlatter, strawberry muffin syndrome, Hutchinson syndrome, and Pepper syndrome. A, B, C, or D? Good job. Oops, I'm sorry, I'm pressing the wrong thing. Yeah, so the correct answer is D, stage 4S, MS, or Pepper syndrome, known as blueberry muffin, not strawberry muffin. That was a trick question. Next up, which of the following molecular alterations can be both sporadic and germline in neuroblastoma? 1P, now this may be more than one answer. 1P11Q, ALK, NMIC, or CMIC? I don't know anymore which the answers are. B, good. ALK is one of them. B, ALK is one of them. Very good. So the correct answer is actually A and B because they may be sporadic and germline. Next up, which immunohistochemical stain can be used to identify neuropil? Keratin cocktail, nonspecific enolase, FOX2B, or GFAP? I see a lot of B's. Let me see a DNA. Okay, the answer is non-specific enolase. FOX2B, I'll tell you, FOX2B will actually only identify the neuroblastic nuclei. Then it will also identify, ganglion cells, differentiating ganglion cells, etc. GFAP may recognize the neuropil, but it's not a great stain for that because my personal feeling, and I'm not a neuropathologist, so forgive me, but it stains a lot of other things in the background. And of course, keratin cocktail will not stain the neuropil. Okay, next up, what tests are usually performed by the Children's Oncology Group on SNAP frozen tissues in cases of neuroblastoma and ganglioneuroblastoma? Loss of heterozygosity, NMIC testing, ALK amplification, or whole genome sequencing? I know this one is a hard one, but it has changed over the years as well. So I'll just give you the answer because it's A, B, and C. So in the past, I will just say that in the past, we used to send a lot of things for SNAP frozen. Now we don't need to do B and C, actually, just ploidy. So loss of heterozygosity testing, we can do some of it via the FFP that we get. And here are just a few challenging diagnoses. So you have a negative primary mass and a positive bone marrow. So the primary mass is negative for tumor and the bone marrow is polydifferentiated neuroblastoma. So what would the diagnosis be? If you have a negative primary mass and a polydifferentiated neuroblastoma in the bone marrow, then it would be considered polydifferentiated neuroblastoma, even if your primary mass biopsy is negative for tumor. And then if you have a positive primary mass and bone marrow biopsies with differing histology. For example, your primary mass is undifferentiated neuroblastoma, but your bone marrow shows a poorly differentiated neuroblastoma. What would the diagnosis be? Then it would be considered poorly differentiated neuroblastoma because we move from this category of undifferentiated to a little bit of neuropil, and that's more differentiated, so it'll be considered poorly differentiated. Here's another example. Your primary mass is ganglion neuroblastoma, but your bone marrow shows poorly differentiated neuroblastoma. Well, what would the diagnosis be? At that point, you should be thinking ganglion neuroblastoma nodular because you have a ganglion neuroma, but in your bone marrow, you have a poorly differentiated neuroblastoma. And I think that's it. We have 3 minutes left. I'll open the floor for questions. I hope you learned something from this short lecture. People can spend all day talking about neuroblastoma, quite honestly. And that's it for me.
Thank you very much, Dr. Sonja. That was a really wonderful lecture. Dear participants, if you have any questions in the remaining few minutes, please, you can raise your hand or drop your questions on the Q&A. Okay. Any questions, comments, perspectives from the Ethiopian side, difficulties in your clinical practice, feel free to share them.
Thank you, Dr. Sonia, for this really nice presentation and for the informative lecture that you gave us today. In our setup, in our experience in Black Lion, we did a review for the past 5 years, and we only got like 2 cases of neuroblastoma. But overall, in sub-Saharan Africa, neuroblastoma seems to be, the occurrence seems to be a little bit low. I'm not exactly sure if it is due to the absence of diagnosis or the reporting, but it seems to be a little bit on the low side. But we still get biopsies, particularly now we get a lot of core biopsies. So we have a nice pointers from your presentation. But just to ask you, because this is kind of like a resource strained setting, if we get, for example, a core needle biopsy that is like an undifferentiated neuroblastoma, where we don't have like suggestive features, the neuropil and all the other differentiations, yes, then what primary antibodies, for example, for a retroperitoneal tumor, should we select as 3? If I ask you to give me 3 antibodies for a differentials in retroperitoneal tumor, one of them being undifferentiated neuroblastoma, that's my first question. The second question, just briefly to say MKI, I think that's very interesting. I just want to ask, can we use it as a reflection of the MIC status and then include it in the risk stratification? Because our clinicians mostly just use the age and the stage for that purpose. That's it. Thank you.
I think for your first question, I would choose the 3 that I would choose that are most useful because of that particular location, besides the FOX2B, to kind of rule out obviously neuroblastoma. I would throw in a WT1 because Wilms tumor is right there. If especially you said retroperitoneal, it's like kind of adrenal location. And then the other thing that I think will be super challenging would have to be like NKX 2.2, because I feel like you can sometimes tell the lymphoid lesions from one another just by the way they look, but Ewing sarcoma in the soft tissues would be more challenging, I think, and therefore would need immunohistochemistry. Of course, if you told me to add any more to the panel, the next thing I would throw on there is probably a TDT to kind of make sure that there's no, or at least some lymphoid marker to make sure that it's not lymphoma as well. I think those are the 4 main differentials, particularly in that location and of that age group, that you might want to do that. And I see someone just threw in the chat, how do you make a diagnosis of neuroblastoma from other small round blue cell tumors in the bone marrow sample? I mean, we are heavily, and I will say heavily, reliant on immunohistochemistry, but morphology, I think, will be very useful because these tumors tend to have, sometimes have salt and pepper nuclei. If you're fortunate in your biopsy, in your bone marrow biopsy, you will get some differentiated neuroblasts. You may get some differentiating neuroblasts. So you can tell based on the fact that the nucleated cytoplasmic maturation is abnormal. And sometimes that is very useful. I mean, it can be very challenging, and no doubt. But those are just tiny things. Like I mean, the person that taught me when I lived in the Caribbean was a man who was a total morphologist. We had very limited access to immunohistochemistry, and so I really do appreciate that morphology can help a lot. But certainly immunohistochemistry, just doing it, and just doing a FOX2B on the on the sample can actually make a big difference in just making that diagnosis in one shot, basically, because one stain can actually help you make that diagnosis if all the cells that you're concerned for are positive. And then you would only be doing like one immunohistochemical stain. But of course, again, that comes back to knowing the clinical history and understanding all of the parts of what's going on in terms of treatment and staging. Rahel, I don't think I answered the last half of your question, but I see that it's 8:03 and I know that we need to go to the next lecture. So if you want, I can answer it afterwards, or I can answer it at another time. But I think we might have to move to the next one if that's okay.
That's okay. You can move on to the next one. Address it if you have to.
Sorry, I just realized my audio was off. Okie dokie. So now we're going to look at another small round blue cell tumor in almost the very same location, Wilms tumor. So this one, again, I have a quiz at the end, so be prepared. I'm just kidding. Just be prepared that there will be questions. And again, I go through historical aspects, clinical characteristics, grossing, histology, biology, genetics, staging, risk stratification, and treatment. And so here we are. In 1872, Ebert was the first person that actually recorded the accurate description of nephroblastoma, and he actually called it myoma sarcomatodes renum, essentially a muscle-looking tumor that is really ugly and in the kidney. And he theorized that the tumor was actually derived from remnants of the Wolffian body that was incorporated into the metanephroblastoma. And for over 20 years, there was a huge battle over the origin of the tumor. And then in 1899, someone else theorized that the tumor was derived from primitive undifferentiated mesoderm, because he thought that, normal development gives rise to the myotome, sclerotome, and nephrotome, and mesenchymal tissue gives rise to smooth muscle. So a lot of people were under the impression that this lesion was of smooth muscle derivation. It was not until Carl Maxim Wilhelm Wilms actually looked at this tumor and really characterized it in his book, The Mixed Tumors of the Kidney. He also developed a number of medical innovations because he was a surgeon as well. So let's talk a little bit about the distribution of pediatric renal tumors. I told you a little bit about the history, so now let's talk about the distribution. So when we think about the most common pediatric renal tumor, we think obviously of Wilms tumor. And it has a very good 5-year overall survival, and there are many molecular alterations that are responsible for Wilms tumor. So we'll talk a little bit about those in the future. Then we think next of renal cell carcinoma, although it's not as common. I mean, like, you don't really think about it in kids personally. I feel like I think about it in adolescents and young adults, and the frequency is about 6%. The 5-year overall survival rate is lower because of the fact that most of these are translocation or syndrome associated. And then the next step is clear cell sarcoma, which is about 3.5% with a 90% 5-year overall survival and has obvious molecular alterations. Then congenital mesoblastic nephroma, somewhere between 2 and 4%, a really good overall survival rate, and also has known molecular alterations in the majority of the cases. And then finally, malignant rhabdoid tumor, which is a very low frequency, but a terrible, terrible outcome. And it's due to a specific molecular alteration. So this is data from the National Cancer Registries here in the US, and you can see that, the incidence of nephroblastoma or Wilms tumor per 1 million is about 5.8. So in patients less than 20 years of age. And one thing that I want you to notice is that as the child ages, the incidence of Wilms tumor drops and the incidence of renal carcinomas begins to rise. And this is what I was saying. Like, I think of renal cell carcinomas in the adolescent and the young adult, and very infrequently will you find it in children less than 10 or even less than 15. So as I mentioned, the incidence is about 10.4 cases per million children in less of those that are less than 15 years. And also you can find them in infants in 0.2 cases per 10,000 infants. Males tend to be less involved than females. So if you have unilateral Wilms tumor, the ratio is 0.9 to 1. And then in bilateral Wilms is 0.6 to 1. In terms of males versus females. So females more often affected. And then mean age of diagnosis in unilateral Wilms tumor, they're slightly older than those patients who have bilateral Wilms tumor. And just to keep in mind, about 10% of children with Wilms tumor have an associated congenital malformation syndrome. So we tend to, once we have a patient with Wilms tumor, send for germline alterations in order to identify whether there's another underlying congenital syndrome. And so how do these patients present? Typically with an abdominal mass, as you see here in these patients. They may also present or complain of abdominal pain. They may have hematuria, hypertension, and fever. And in some small percentage, they may present with coagulopathy, such as acquired von Willebrand syndrome. Here is an example of a case wherein the patient had an acute abdomen, obviously presenting with abdominal pain because of tumor rupture and uncontrolled bleeding. Fortunately, this looks like it was, kept well maintained by Gerota's fascia, at least if nothing else. Very little perinephric fat out here, but so sort of not allowed to leak into the abdomen. And as a result, this patient was able to have surgery without passing away. So one thing I will challenge you to remember about Wilms tumor is that there are two different societies which are responsible for helping us with taking care of these patients in the oncologic world. So there's SIOP, which is the International Society of Pediatric Oncology. And then there's the COG, which is the Children's Oncology Group. The Children's Oncology Group is what we typically use and follow here in the United States. And SIOP is really utilized by lots of my European colleagues. What's the difference? Well, in the SIOP group, they typically image first. They make a decision on what this is. They give the patient preoperative therapy. Sometimes they biopsy before, and then they give the patient preoperative therapy. And then they do surgery, then they do chemo and radiate. In the United States, for Wilms tumors, people image. They do surgery once the tumor looks resectable, and then they'll do chemo and radiation. The only time this pathway is not taken is when it is not possible to do an easy resection rather. And so if you have a difficult resection, you have tumor that's going in multiple places, then the patient may end up with chemo and radiation, and then undergo excision if needed. So here's a gross image of a patient with a single tumor. And then here's a patient with multiple tumors. So in this patient with multiple tumors, what question would you ask about this patient? I don't know if I can see the chat right now. Let me just see. What question would you ask? So a patient with multiple tumors of different sizes and lesions along the cortex. What question would you ask? I'm trying not to make sure that people in the audience don't fall asleep. If you haven't thought about it, then the question that you should ask about this patient is, does the patient have a predisposing syndrome? So most patients with Wilms tumors, as I mentioned, have a single lesion. But when you start seeing lesions that are multiple, this patient probably has nephroblastomatosis, which is small rests in the cortex, and that results in other Wilms tumors developing within that nephroblastoma region, so nephrogenic rest rather, sitting all throughout the cortex, and then developing Wilms tumors within them. And of course, that patient probably has a predisposing syndrome. So let's talk more about the gross, because the gross examination of your Wilms tumor is what really will help you to help your patient. So there's specific issues with specimen handling, and the most important factors include documentation of capsular invasion, hilar and sinus involvement, and adequate sampling of the tumor. And then, of course, they're all related to staging and overall prognosis. So one should make sure that they document if there's any capsular involvement or invasion, like in this case. You should make sure to put in, some people, judiciously put in the entire hilum and sinus in order to identify whether or not there's hilar or sinus involvement, particularly like this tumor, which looks very botryoid. And then, of course, adequate sampling of the tumor. You want to make sure that you show whether or not the tumor is leaving, if it's going into large vessels, if there's lymphovascular invasion, if there are adjacent nodules, or if there are any other lesions that are around. So this, I'm just sharing one of the ways that one could grow. So this is one of the things that some of my colleagues do here. You can, using an intact nephrectomy specimen, you get an entire slab or a cross section that is cut. We don't remove the capsule, of course, and we ink the surface. Of course, before you actually cut into it, you should weigh, photograph, ink, and then bivalve. We do this for every specimen anyways. And then we inspect the renal vein for invasion, and then we map. So we put this entire slab in. That's a lot of sections, yet 20 sections from just this one slab. And then sort of, make a map so that if you had an area that looks more poorly differentiated in T4, for example, and then an area over here which looks like a ganglioneuroma, then you probably have a ganglioneuroblastoma intermix. Do you need to do it like this every single time? Absolutely not. It's just an approach that some people have taken. So let's move on to the histology with some definitions and terms. The three components of typical neuroblastoma include an epithelial component, a blastemal component, and a stromal component. If you've got all three, then you call it triphasic. If you only have two, then it's biphasic. And if it's only one, it's monophasic. It's favorable histology. Remember, in neuroblastoma, we have favorable and unfavorable. So it's a similar principle here. Favorable histology is that you can have any or all of these components, but you can't have anaplasia. And I'll tell you what it means, but essentially it's unfavorable if you have anaplasia being diffuse or focal. And then there's a category in between anaplasia and not quite anaplasia, which is called severe nuclear unrest. It's defined as nuclear pleomorphism or atypia approaching the criteria of anaplasia, but it clinically and pathogenetically resembles favorable histology. So unless you have super duper anaplasia that's easy to identify, then you should always be calling these lesions favorable. That's just the tip. So here is the blastema. It is beautiful and small and round and blue and has a high nuclear to cytoplasmic ratio. You can't really tell what kind of tissue this is trying to make. And by immunohistochemistry, it'll be positive for WT1, diffuse nuclear positivity. It can be positive for CD99. Unfortunately, that's focal. However, it shouldn't have nice, strong membranous staining that you would see in an Ewing sarcoma. It can also have positivity for some of these neuroendocrine markers. So, I mean, if I had to just choose one marker, I would only choose WT1. I don't want to get confused by some of these others, but I'm just putting them in there so that you know there's some overlap with immunohistochemistry. And cytokeratin may also be present. What's usually negative are markers for other things like NKX 2.2, which is a marker for your Ewing sarcoma. Blastema might have other growth patterns, which are very interesting. Here's a kind of serpentine pattern. This one looks kind of basaloid. This one looks very nodular. And they kind of look diffuse because sometimes, you are trying to figure out what kind of tumor it is, but if it's only blastema or if it's blastema predominant and that's all you got, then it might become a challenge as to which small round cell tumor this truly is. Next up is epithelium. It forms these beautiful tubular structures that look like rosettes, but they are not really rosettes because they have true lumens, right? And they also may have areas that replicate or try to look like a glomerulus. So they're considered glomeruloid. Those rosette-like areas may be morphologically similar to neuroblastoma, like these, because they may not have a nucleus because, a luminal structure that's readily identifiable. And again, they can be positive for WT1 nuclear-wise, and they can also be positive for cytokeratin in the epithelial component and should be negative for other markers. Finally, the stroma, they are stellate cells within a myxoid background to spindle cells, and they recapitulate primitive mesenchyme. So typically, they're these nice long cells. They have small nuclei that can be elongated. This one has a sort of myofibroblastic kind of differentiation, almost to the point that you might be thinking that this might be myoid. So you can also have smooth and striated muscle. They're the most common differentiated stromal types, but you can also see fat, cartilage, osteoid, and even glial tissues present. And again, they should be positive for WT1, and then BCL2, they can also be positive for if you're trying to differentiate them. So what is anaplasia? Because we talked about all the things that represent favorable histology. Now we want to talk about all the things that represent unfavorable histology. So that's anaplasia. Anaplasia includes nuclear features, which are hyperchromatic, aneuploid, and or have nucleomegaly. Here is an example of one, a very, very large nucleus that is huge and multipolar, or polyploid rather, and it's at least 3 times the size of its neighbors. And then atypical mitoses, which may be multipolar or clearly aneuploid. And here's one that looks like Mercedes-Benz sign. So you know that something's wrong here. Here's another one that looks like a T. Here's another one that looks like Mercedes-Benz sign or Y. So all of those are atypical mitoses. So you should have both of those features, large nuclei as well as atypical mitoses, and those would be enough to call anaplasia. The one thing I will mention is that anaplasia is not thought to be affected by therapy. So if it is present, it will still be present after treatment. And then it may be focal or diffuse. So what does focal mean? There are many definitions of focal. Essentially, no anaplasia should be involving renal vessels. Anaplasia must be confined to 1 or 2 little regions within the primary tumor, and each focus must be surrounded on all sides by non-anaplastic tissue. And then the remaining tissue should not show severe nuclear unrest. Also, if you did a biopsy and you found anaplasia, this would not be considered focal. So here's a good example of a gross image of a Wilms tumor that has a little capsule here on one edge, probably the renal capsule. And then you can see a clear lesion that is rounded that turned out to be focal anaplasia. So this one now, diffuse anaplasia, moving along, is present in any extrarenal site. So if it's in the sinus vessels, extracapsular, nodal, or distant metastases, if it's present in a random biopsy, then it's diffuse, and anaplasia is unequivocally identified, but the tumor fails any of the above criteria for focal. So if it's just surrounded on some sides by other severe nuclear unrest, then it's enough to call diffuse anaplasia. That's an example of what it would be like. And here is an example of, on the right-hand side, of severe nuclear unrest. So here's your normal Wilms tumor, and they call it grade 1 or minimal. But as you notice, the nuclei are starting to get larger on the right-hand side. The reason why it's in black and white is because very few people, this is when it was described, but very few people actually call severe nuclear unrest at this point. As in my career, I haven't seen very many people call severe nuclear unrest at all in many of their cases. And so it's a challenge even to find cases that have this like severe nuclear unrest. Usually they are anaplastic if you keep looking. So I've just described to you that anaplasia encompasses all of the features basically of unfavorable histology. And how many patients does that really affect? About 5 to 10% of patients who have Wilms tumor. They're typically 36 months of age and older, so they are older patient population and more common in the non-white white ethnicity. The presence of anaplasia may either be diffuse or focal, as I mentioned, and in bilateral tumors, at least almost like 15% have been reported to have anaplastic histology in one kidney. So if you have bilateral tumors, look out for anaplasia. And it correlates with responsiveness to therapy rather than with aggressiveness. So now I've talked about unfavorable histology. I've talked about anaplasia, how we look at a histology for that. But now tumor biology plays a very big part in the expression of these tumors as well. And this list is huge. I know we're going to go through a couple of them, but I want you to be aware that a lot of these tumors are obviously driven by these genetic factors. And so we'll talk a bit about the ones that are very important. So here's WT1, which is mutated in the germline or somatically in about 15% of Wilms tumors. The median age at presentation is about 44 months, and it has a vital role in nephrogenesis and glomerular function in the mature kidney. The germline mutations result in Weger and Dennis-Trash syndromes and somatic WT1 loss with incidence dependence on patient ethnicity. And then you can have mutations in WT1 in your intralobar nephrogenic rest. That's really important because when you do your gross examination of your kidney, if you find nephrogenic rest that are of an intralobar location, you may be able to suggest, well, there might be some underlying predisposition here. And so what does WT1 do? Because that's really important to understand how everything works. So WT1 is essential for mesenchymal to epithelial transition and formation of that nephron. And it's a direct transcriptional activator of the Wnt process, and that, of Wnt, the protein, and Wnt regulates that mesenchymal epithelial transition. So here you have the metanephric blastema, and when Wnt is applied, then you start forming your tubules, right? See here, you have a tubule going down. Oops, my bad. Then you start forming your tubule. So you go from mesenchyme, which is your renal vesicle, to epithelium. And that force is basically driven by WT1. So without it, you can imagine that now you end up with more mesenchyme, which can turn into your blastema, and you have, less normal epithelial derivation and normal nephrons. So here we have one of the syndromes that is driven by WT1 alteration, which is Wilms tumor, aniridia, genitourinary anomalies, and mental retardation. The G also for the genitourinary anomalies include ambiguous genitalia and our friend gonadoblastoma. It's a small percentage of Wilms tumor patients, but about 30% of those patients will actually develop Wilms. And the etiology is due to a deletion in the WT1. And here you can see the aniridia in this patient. Next is Dennis-Trash, which also results in Wilms tumor, but one of the very characteristic, this is one of those things that they test on boards, very characteristic thing to find in Dennis-Trash is diffuse mesangial sclerosis. Right here in the center, you can see this pink stuff kind of filling up the mesangium, obviously preventing your tubule from functioning. And you can see these little protein deposits inside of your Bowman's capsule. And then it obviously results in end-stage renal failure. The other thing that these patients have is gonadal dysgenesis. So they have male pseudohermaphroditism, wherein you can see here these very large, almost labial type folds, and external ambiguous genitalia, because this looks like a megaclitoris, but it's probably a penis in this child. And then this is as a result of an inactivating point mutation of WT1, usually presents at around 18 months, and 20% of these patients will have a bilateral Wilms tumor. So how do I remember that? Because this is a thing that is tested for Dennis-Trash, definitely not a deletion of WT1. That's all. That's something that I usually put in there for my residents and fellows to remember. Other syndromes associated with the WT1 include Frazier, Beckwith-Wiedemann, Simpson, Galabi, Behmel, Sotos, Perlman. There's a lot. And even here, you see I have a number because things have been discovered and changed. So it used to be unknown, and now we actually know it. So with time and more patients, we are actually able to identify what are the genes that have association with Wilms tumor. So I'm just going to put it into a different category, meaning those that are high risk versus moderate versus low risk. So those that are high risk have a more than 20% chance of developing Wilms tumor, and that includes that WT1 that I mentioned. And then moderate risk are people like those that have Beckwith-Wiedemann, those that have GPC3 mutations, and then low risk of patients with leishmania and trisomy 18 and 13, which we see, I think, more frequently than those with the WT1 deletion. So what other syndromes are associated with Wilms tumor? Should we be screening for them? So generally, we do screen for those patients by imaging and physical examination. Next gene that is important to mention is WT2, and it's the most common sporadic event in Wilms tumor. They mostly have loss of heterozygosity and loss of imprinting associated with 5 times risk of recurrence. And these imprinted genes include IGF2 and H19, and they're both sort of tumor suppressors and embryonic growth factors. So you can imagine if you get rid of your tumor suppressor, well, you'll have growth. And if you have an embryonic growth factor that is switched on, well, you'll have growth. And so both of those things together actually result in the proliferation of these tumors. And it is associated with perilobar nephrogenic rest as well. So I've been talking a little bit about nephrogenic rest, and both WT1 and WT2 are found in these nephrogenic rest. So what are they? They're abnormally persistent clusters of embryonal cells that represent microscopic malformations or dysplasias of the developing kidney. We can see them in about 1% of normal kidneys, but 30 to 40% of kidneys with sporadic Wilms, and in almost 100% of cases with bilateral Wilms, which is why on your gross examination, if you see multiple nodules, you should be thinking, do you have an underlying genetic disorder? Because that might be very predictive of what's on the other side. Imagine they took out one kidney and you find lots of these nephrogenic rests. Well, I'm sure that on the contralateral side, there's involvement. And so the categories are intralobar and perilobar, most commonly seen in Asian children. And then the mutations are in WT1 and WT2. And here are the just locations of the different kinds of rest. So here you can see a perilobar rest. Here is an intralobar rest. Here is a panlobar rest. And this one is diffuse hyperplastic perilobar rest, like we saw in that case that I showed you the gross on earlier. And here are histologic examples. So in general, these perilobar rests, they sort of intermingle with the normal. They don't have a well-circumscribed capsule. And you can see even here, you can see them kind of sneaking in between. They don't look, they do look different, and they obviously look more hyperplastic or more, what's the right word? More proliferative. And sometimes they have mitoses, they have a higher nuclear to cytoplasmic ratio, so they obviously look like tumor, but they don't have a capsule like you would expect to see in a Wilms tumor. They're unencapsulated and they sort of just sneak in between the normal. And that's how you will identify a nephrogenic rest from a Wilms tumor, because some of these do undergo change that looks like a Wilms tumor. And here again, I mentioned some of the associations. There's Pullman, there's Weger, and these are associated with perilobar and intralobar nephrogenic rests. So how does this really happen here? This is just another table, another pictorial that shows you here's a perilobar rest and from WT2. And if you have multiple mutations, you actually end up developing epithelial or blastemal predominant Wilms tumor. And then on the contralateral, you have intralobar rests that you see in Weger and Dennis Trash, and that's run by WT1. And with additional mutations, you may actually develop a stromal predominant or mixed type Wilms tumor. So very important to identify these rests because most likely they are present bilaterally. So that's the that's one thing. But now, another thing is that you may also have nephroblastoma, which is essentially the presence of multiple or diffuse nephrogenic rests. So you see in this patient, you have two kidneys. That's one kidney here, and that's really ridiculously involved. But here's another kidney that also has multiple lesions. Similarly, you can see here, this one, I'm sorry that this is in front of the other, but they both have these numerous lesions. And so you can have multiple or diffuse nephrogenic rests and may present as a single focus or multiple confluent foci, and that's known as nephroblastoma. Moving on to another gene, or loss of heterozygosity, actually, which is another part of tumor biology. We've seen that in already in neuroblastoma as being important, and similarly in Wilms tumor, no surprise. So loss of heterozygosity for 1p or 16q will result in recurrence in some patients and may just be the driver of disease in others. And it suggests the presence of tumor suppressor or tumor progressive genes at these locations. They have a worse relapse-free and overall survival rate. And a gain of 1q is associated with inferior survival in about 30% of favorable histology Wilms tumors. In addition, TP53 mutations can be seen in about 75% of these tumors. And so what do we do now? We test for loss of heterozygosity as standard of care, and we usually, well, because we are a COG site, we usually actually do tests on SNAP frozen tissue or formalin fixed paraffin embedded tissue. The next gene is beta-catenin, and that encodes, the protein beta-catenin that regulates coordination of cell-to-cell adhesion and gene transcription. It's seen in about 15% of Wilms tumors and is a gain of function mutations and a strong association, usually coexisting with WT1 alterations. WTX, found in about 6 to 30% sporadic Wilms tumors, and these are germline mutations. These patients have sclerosing skeletal dysplasia, osteopathy, striata congenita with cranial sclerosis. There's a really nice paper down here that I have from the PDP in 2017 that really goes through these WTX patients, but there's no clinical or pathologic distinctions. When you see a Wilms tumor from a patient who has the WTX abnormality, you won't be able to tell that this is obviously a patient who has WTX unless they have sclerosing skeletal dysplasia or some other finding in their history that will be able to point you in that direction, or you just do the germline. Next up is MYC-N, an amplification of MYC-N. We know that it's already bad in neuroblastoma, but it's associated with diffuse anaplastic Wilms tumor. And occasionally it's seen with Wilms tumor without anaplasia. So of course, increase in copy numbers of MYC-N is what is normal, but it is less than what you see in neuroblastoma. So the copy numbers in neuroblastoma is something like 10. So this is probably 3 or 5 when we're thinking about Wilms. And so next part of the tumor biology is TP53 alterations. And this occurs in about 5% of Wilms tumor, but in 70% of all anaplastic Wilms tumor. So really important to keep in mind that when you see an anaplastic Wilms, you're thinking TP53 alteration at the top of your list. And that can be either somatic, meaning that it's only in the tumor, or germline, meaning that the patient has Li-Fraumeni disease. And of course, it is associated with high risk and anaplastic histology. These two are less well known, but you can see that they occur in about 18% of PSYOPs high-risk blastemal tumors. So they are blastema predominant tumors, and about 7% of the pre-therapy favorable histology Wilms tumors. They had reduced event-free survival and overall survival when they were found in combination with these microRNA mutations. And this is just the microRNA processing pathway, just to show you how, these tiny things that are proteins that are just, participating in the development of normal functions in the kidney actually associated with Wilms tumor. And you can see those that are inactivating here in blue and those that are activating in green, which is Lin28, which is not too much. So I'm only going to put a little throw in here for DICER1 because it's one of my favorite genes, and DICER1 germline and somatic mutations have been associated with Wilms tumor. In about 2.5% you can find patients with somatic DICER1 alterations. And does anyone know about DICER1 germline mutation? Because I feel like there are quite a lot of other diseases that patients with DICER1 have. So you can develop pineoblastoma, pituitary blastomas. You can have, of course, pleuropulmonary blastoma, which is the classic and canonical DICER1 alteration that's found in the lungs, cystic lungs of little kids, but cystic nephroma, as well as ovarian sex cord stromal tumors, thyroid disease, nasal chondromesenchymal hematoma. There are lots of things, and embryonal rhabdos do occur in those patients who have DICER1. So just something to keep in mind if you have a patient who they may present with something else before they present with their Wilms, and you might want to keep that in mind for a DICER1 alteration. So we've talked a lot about the molecular now, and now I'm going to move a bit to the prognostic variables. So the prognosis for patients with these tumors, Wilms tumor, depends on what we've talked about. The tumor histology, favorable versus unfavorable anaplastic histology. The stage of the disease at diagnosis, we haven't really talked about that. The molecular findings of 1q gain and loss of heterozygosity. And 1q gain is the most powerful predictive outcome and is definitely associated with an adverse outcome, very similar to how we have molecular alterations that make a difference in neuroblastoma. And of course, age. So an older age is associated with an adverse prognosis. So now I'm going to move to treatment and staging, which we haven't really talked about a bit, but it's really very important because treatment and staging has been developed on the basis of these two multidisciplinary cooperative groups, the PSYOP and the COG, which I had mentioned to you earlier in neuroblastoma. So what is the general principle? In COG, the general principle is upfront surgery. If you can remove that kidney without any without touching any other structures, that's what they'll do. They will not put chemotherapy, they will not biopsy it, they'll just remove it. What's the advantage? Of course, it makes your staging easier because you have the natural biology of disease, collection of biologic materials that are unaltered by therapy. You can remove the main tumor and you decrease the risk of upstaging, and we'll talk about what that means. And then what are some of the disadvantages? Obviously, if you decide to remove this tumor, it's usually a very large tumor at surgery, and sometimes it's a very difficult surgery. So the risk of tumor rupture is very, very real because these tumors can look necrotic and they can be very soft. They can erode and get all the way through to gyrotous fascia and make it very easy to rupture. And then finally, irradiation may still be required after the initial surgery. And next, I will move to the PSYOP approach, which essentially is upfront chemotherapy plus or minus radiotherapy, and then they do surgical excision. Of course, this prevents tumor rupture because you treat the tumor before you remove it, and then it downstages the case once because the size of the tumor may change as a result, and because of treatment, you may actually alter the histology. Reduces the need for irradiation because you kind of, consolidate the tumor first and then you remove it. And then, of course, it can identify a chemo-resistant clone if it's present because that might benefit from treatment intensification. What are some of the disadvantages? It alters the histologic features and the distribution of subtypes. So I think although we practice in the COG realm of things, occasionally we have patients who have upfront chemotherapy and then go to resection. And those are the most challenging ones to identify the histologic features because now they don't look the same. And they have a lot of treatment effect. And it's very challenging to even sometimes figure out what you're dealing with. And of course, it makes staging more difficult because instead of tumor, I have treatment effect, maybe I have a few tumor cells. It's really challenging. So I'm going to show you a little bit about the staging, and what I have highlighted in yellow essentially will be differentiating one area from the COG versus PSYOP. And so here in stage 1, this tumor, as you can see, is limited to the kidney and completely resected. It's not involving the renal capsule, and that's the same in the PSYOP. And no residual tumor is apparent beyond the margins of resection. In this one, you shouldn't have any involvement in the renal vein and renal sinus. However, here in the SIOP, they can have renal vein and renal sinus involvement, and you can even biopsy the needle with a needle. But in COG, you would not call this a stage 1 if you were biopsied at all. And of course, you can't have lymph node metastasis or anything like that. Next up is stage 2. I think the major difference between stage 2 and between the COG and SIOP at stage 2 is that they permit a needle biopsy. Everything else is about the same, but now the renal vein can be involved, and it's not attached, or it's not been transected. Other sites like renal capsule can be involved. It can now start growing through. But again, needle biopsy is permitted in SIOP stage 2. So if you got a biopsy and it fulfills all the other criteria, then you'll only be at stage 2. However, it would not fall within the COG stage 2 criteria. It would actually fall into stage 3 COG criteria because you have already biopsied that tumor. If you have tumor rupture, if you have tumor spill, any of those, if you have biopsy before definitive surgery, that upstages you to a stage 3 in the COG staging system. However, in SIOP, you would have already been a stage 2, and that's fine. All the other findings like tumor presence at the margin, abdominal lymph nodes, peritoneal tumor involvement, all those other things are similar between the two groups. And then in terms of stage 4, they're fairly similar. Hematogenous or lymph node met outside the abdomen. This one is describing, in SIOP, they describe hematogenous or lymph node met outside the abdominal pelvic region. And then finally, both COG and SIOP agree that bilateral renal tumor at diagnosis is what is considered stage 4. And you can see here images of a couple of patients with bilateral renal tumors. So I mentioned that post-therapy histologic classification is very important, and we do use it a lot for, of course, in Europe, people use it a lot, but we do also use this staging system or histologic classification system once we have a post-chemotherapy or post-therapy treated patient. And usually those that are low risk have no viable Wilms tumor present other than scattered nephroblastic tubules that could represent residual nephrogenic rests. Those that are intermediate risk either have viable tumor comprising less than 33% of the mass or viable tumor comprising greater than 33% of the mass with blastema in less than 66% of viable tumor, meaning that you should have anywhere between 30 to 66% of blastema. And then if you have any more than that, sorry, my bad. You should have less than 33% of blastema, but it should be in less than 66% of viable tumor. If you're high risk, your viable tumor is greater than 33% of the mass with blastema histology greater than 66% of the viable tumor. So high risk equals more blastema. Intermediate risk, less blastema. Low risk, nothing at all. There should be no blastema because blastema is what ultimately drives the biology of the disease. And usually when we are looking for molecular alterations, usually they are found in the most undifferentiated component of the tumor. And in the case of Wilms, the blastema is the most undifferentiated component. So how do folks risk stratify? Well, you can see here that in the COG, if you have a favorable histology of Wilms tumor, you are immediately in the intermediate group. However, you're high risk if you're any of these, if you're anaplastic or unfavorable. However, in the SIOP, because of the treatment that is employed prior to excision, there are many different groups. So if you have nephroblastom that looks cystic and is partially differentiated post-treatment, you'll actually be considered low risk. If you have a completely necrotic nephroblastoma, you actually considered low risk. Anything else beyond that, unless you have focal anaplasia, you're intermediate, and diffuse anaplasia, you become high risk. So there are clear differences in terms of risk stratification, which will then ultimately be expressed in the fact that treatment outcomes are slightly different depending on where you are in the world because of what is put into the risk groups. I'm just going to show you this very quickly. So treatment obviously is based on histology. Oh, my things are, here. So you go, if you have stage 1, typically they're getting surgery, lymph nodes, and chemotherapy. If you're at stage 2, you're getting a nephrectomy, lymph nodes, chemo, sometimes you get radiation. If you have anaplasia, typically patients who have anaplasia are getting radiation. They should be getting radiation. And then as the stage increases, and as you can see, the overall survival starts going down, especially in those that have anaplasia, there's more and more additional treatments and therapies directed to, if you have metastasis or pulmonary lesions, you get radiation, etc. I wanted to talk a little bit about preoperative chemotherapy in our setting, because we don't typically see this a lot, but this is important because preoperative chemotherapy is sometimes very important for a child who cannot undergo an initial primary resection. So when is it indicated? When you have a Wilms tumor in a solitary kidney, that is huge. When you have synchronous bilateral Wilms tumor, because you want to spare kidney, then you generally opt for pre-op chemo. When there's extension of tumor thrombus into the inferior vena cava above the level of the hepatic veins. So about 4% of patients have inferior vena cava or atrial involvement. I've seen that in only about 2 cases in my life. And then 11% of patients will present with renal vein involvement, which is far more common. I've seen quite a few of those. Atrial involvement is very rare. And then, of course, this also does happen, but there's embolization of a caval thrombus into the pulmonary artery, which I've only seen once. And then, so the tumor typically, another reason, sorry, for preoperative chemotherapy is when the tumor involves contiguous structures. So the only means of removing the kidney requires removal of other structures like the spleen and the pancreas and all these other things. So you do chemotherapy to decrease the size and the burden of surgery. And then, of course, if it's considered inoperable, so the tumor has spread all over, it's all in the retroperitoneum, it's impossible to excise easily, then preoperative chemotherapy will be performed. And then, of course, if there's pulmonary compromise because of extensive pulmonary metastasis, this patient will most definitely have preoperative chemotherapy with airway maintenance in order to minimize the amount of surgery that they will have to undergo. So I think we're upon the hour. So the take-home points. Wilms tumor is the most common. Oops, I'm gonna pause for a second because there's a lot of noise in the background. Okay. So it's the most common it's the most common pediatric renal tumor. Good grossing, as I mentioned in the beginning, is really crucial for the staging and for ensuring that we give the patients the best prognosis that we can. Biology studies for loss of heterozygosity and other drivers are really important because they determine how the patient will progress. In general, I will say Wilms tumors are usually triphasic, but always look out for anaplasia. Prognostic factors include the things that I mentioned: age, stage, histology, tumor size, completeness of lung nodule response, and loss of heterozygosity. And I always put this in here because we use the CAP checklist. I like to make sure that my trainees are using it as well. But it's really important sometimes to just make sure that you are checking all the boxes and looking for all of the things that are important, because the CAP checklist for us helps the oncologist give the prognostic value, to the patient. So, oops, I have my quizzes already coming up. Are you ready for the quiz? I'm going to put it up here. First question: which of the following is vital to note when grossing a Wilms tumor case? A, tumor invading the capsule. B, a thin rim of normal kidney. C, tumor transected in the renal vein. And D, presence or absence of adrenal gland. I like that. A and C. Good answer. It is A and C. So of course, if you have tumor invading the capsule, you're going to change the stage, right? And then if tumor is in that renal vein, you will also change the stage, as I mentioned. Of course, it is important to identify these things: normal kidney, where it's present, and presence or absence of the adrenal gland. But it is vital to note those things because that changes the stage, right? The presence or absence of an adrenal gland won't change the stage unless it is involved. All right, next question. You are reviewing a nephrectomy case and you notice the following finding on your slides. that has been labeled uninvolved kidney. What's the finding? Is it metastasis? Is it a perilobar nephrogenic rest? Is it an interlobar nephrogenic rest? Or is it a dysplastic kidney? And you're right, everyone is writing B in there, and that's correct. It's perilobar nephrogenic rest. Very good. Next up, based on the prior findings, what's the likely gene involved? Is it WT1? Is it WTX? Is it IGF2? Or is it TP53? I know this one's harder. You see some answers coming up there. It's actually WT2 or IGF2, because those are associated with perilobar nephrogenic rests. It's the most commonly altered gene in Wilms tumor, and definitely the most often associated with perilobar. WT1 is associated with the interlobar rests. All right, what's the most common genetic alteration in sporadic Wilms tumor? This is a giveaway because I just said it like 2 seconds ago. Yes, good. So D. And then do you know the frequency of each? I'll just tell you because this is harder. So WTX, the frequency is about 60 to 30%. WT1, it's just 15%. Loss of heterozygosity, 17%. And Wilms tumor 2 or WT2, 67%. The other name for this is IGF2. So that's why I tried to hop on, yeah, it sounds like WT1 would be the most important one, but it's actually 2. And I think, oh, why did it do that? All right. I don't know. This is kind of showing up already. A 3-year-old boy with trisomy 18 was incidentally found to have renal mass on ultrasound. Which of the following is true? He's in high risk for WT1, Wilms tumor, sorry. He needs a yearly abdominal ultrasound, and he probably has nephroblastomatosis. Well, you can see the answers here. So it's false, false, true. He probably has nephroblastomatosis because patients that have trisomy 18 do have nephroblastomatosis, but he's not at high risk because they're in the low risk category, and typically they don't recommend yearly abdominal ultrasounds for patients in the low risk category. So here I have the answers down below here. And just to remember, if you have a patient with nephroblastomatosis, clinicians might just follow them until they develop into a Wilms tumor, depending on if it's bilateral or not. So I have seen patients, especially with trisomy 18, being followed. I have 2 patients where they were just being followed and they had bilateral nephroblastomatosis. And it was only until the time of the development of a Wilms tumor that it was even thought about to do chemotherapy first. And no surgery was actually ever performed. All right, I think this is my last question. A 2-year-old boy presented with abdominal pain and a palpable left upper quadrant mass, and he was found to have a large left renal mass with extensive retroperitoneal lymphadenopathy. And then they did a needle biopsy. So what's the consequence of needle biopsy prior to surgical resection in the COG versus PSYOP staging? I know this one is also like not straightforward. But essentially, if you in the COG stage, you're stage 3 because you had a needle biopsy. And if you're in PSYOP, stage 2. Very good, Derar. All right. And here's the renal biopsy. What do you see? Unrest plus this. Look at that. So you have polyploid nuclei, and you have really atypical mitoses. And yes, there are some cells here that are very large, right? But I think I'm just circling them. I think there's a lot here. So based on those biopsy findings, how would you sign? Because this is a biopsy. So how would you sign out the case? Pleomorphic Wilms, Wilms with focal anaplasia on a biopsy, Wilms with diffuse anaplasia, or Wilms tumor with atypia. So the answer is actually C, because if you find any kind of anaplasia on a biopsy, it's considered diffuse anaplasia. All right. Okay, I think I have 2 more questions now that I look at this. And I have a few more minutes. So you have a single section of a renal tumor that looks like this. Single section, if you have a resection. What do you call it and what do you do? It's find the way it is, sign it out as pleomorphic Wilms tumor. B, it's anaplastic, sign it out as anaplastic Wilms tumor. C, it's anaplastic, get more sections. Or D, it's a metastasis, get immunohistochemistry. So the answer would actually be C. It's anaplastic, get more sections, because I only have a single section of this renal tumor that looks like this, right? So if I have it only in one section and I have, say, 4 or 5 other sections and there's nothing, I want to make sure that there's no other foci of anaplasia, right? You need 1 to 2 foci of anaplasia that are well circumscribed to call this focal. If I found, if I took 4 or 5 more sections and in every other section I found anaplasia, then I would call this diffuse. So it's really important to be sampling it more, because I purposely wrote a single section of a renal tumor that looks like this. And so you would want to make sure that you get more sections to ensure that determine whether it's focal or diffuse, because the definition is dependent on the number of sections and the number of sites that it involves. I think, right. And so what gene is likely mutated in this tumor if there's anaplasia? Look at that. That's so amazing. Yes, very good, Yared. So TP53 is mutated in about 70% of all anaplastic Wilms tumor. And finally, this is definitely the last one. This tumor arose in the adrenal gland. So here's the tumor out here, and here is the kidney. Okay. Here's what it looks like on cross section. And here is another little nodule inside of it. It looks different colored, whitish outside and reddish brown. You can't see because it's black and white, but it was fleshy colored. So what's the likely diagnosis? Anaplastic Wilms, favorable histology Wilms, ganglioneuroblastoma nodular, or desmoplastic round cell tumor. And I think I see people writing C. So excellent. C, it actually is a ganglioneuroblastoma nodular. That's just to tie into your neuroblastic lesion. So don't forget how close those things are, right? This is the adrenal here, and that's the kidney. So when you think about things in that general area, you should always, as in pediatric patients, always be thinking, could it be something coming from the kidney, a Wilms, or could it be something coming from the adrenal ganglioneuroblastoma or neuroblastoma? And I think with that, I am done.
Okay. Thank you very much, Dr. Sonja. That was really a warm presentation and quite an interactive session. I think Dr. Christina is also here. We are basically on time. So I think we can proceed with the next session. If we have time, we can invite our participants to forward questions regarding the second and the third session together at the end of today's presentation. Having said that, I think let me introduce Dr. Sonja. Dr. Christina, Dr. Christina is a clinical assistant professor of pathology at Ohio State University at Nationwide Children's Hospital, and she's a member of the Department of Pathology and Laboratory Medicine. Today, she will be discussing the hematologic malignancies. Basically, we will have case discussions, and I think it will be an interactive session too. I will leave the floor to Dr. Christina. Off you go.
Hi, thank you for inviting me today. Can you hear me?
Yes, Dr. Christina.
Okay. It's not allowing me to share the screen.
Okay, let me handle that. Okay. One moment, sorry. In the meantime, you can also introduce yourself.
Hi, I'm Christina Brannick. I am a hematopathologist at Nationwide Children's. I'm an assistant professor at OSU and the director of hematopathology at Nationwide Children's. And Today, I am going to present some cases of pediatric leukemia and lymphomas. I am still not able to share my screen.
I see. Sorry, let me handle that. Otherwise,
That's better. All right, let's see.
Okay.
Can you see that?
great.
Okay, great. Here's my email address if anyone wants to contact me after the session. It's just my first name dot last name at nationwidechildrens.org. So today I have 2 pediatric leukemia cases, and then I also have 2 lymphoma cases that are not uncommon in pediatrics, particularly the first one, but also may be seen in the adult population. So case number 1 is a 3-day-old female with Down syndrome who was born prematurely at 35 weeks and had respiratory distress. She was noted on peripheral blood smear to have a leukocytosis with some immature cells, and the platelet count was also markedly elevated above 1 million. There was no anemia, interestingly. This is a low power view of the peripheral blood smear. You can kind of get a sense that the leukocyte count is elevated and that there may be some large immature mononuclear cells scattered around at a higher power. We do have a number of cells consistent with blasts. Let me see if I can, so I think there should be a laser pointer in here somewhere. Oops, sorry. Okay. So we have a number of cells scattered around that are sort of intermediate to large size and maybe have a little bit finer chromatin, and like this right here and here. And a few of them have sort of these interesting cytoplasmic blebs on them. And this right here actually is a circulating megakaryocyte, sort of a immature or micro megakaryocyte, which you can see that in newborns, and that's not necessarily considered pathologic. But in this particular case, it is in keeping with the overall disease process present. We also have right here in the feathered edge of the smear some interesting stuff going on. There's a blast here with sort of separate nuclear lobes that's sort of reminiscent of a megakaryocyte that you might see in the bone marrow. And there's also a number of granulocytes in different stages, including segmented neutrophils, bands, metamyelocytes, myelocytes. And we also have a number of nucleated red cells on the peripheral blood smear. So to further evaluate the findings on this smear, flow cytometry was performed. I don't know how familiar you are with flow cytometry, so I'll give you a very quick crash course in it. So what we do is we incubate a wet specimen like peripheral blood or bone marrow aspirate with a fluorescently tagged antibody. And we have multiple antibodies to different antigens, mostly surface antigens, in the same tube. And the flow cytometer will detect the fluorescent signal from the antibodies that bind. And each dot on the plot is called an event, which in theory is a single cell. And what we have here are two-dimensional XY plots. Generally, the way it works is the further you go along on the x-axis, the brighter the expression and of that particular antibody. So in this one, CD34. And then on the y-axis, the higher you go, the brighter the expression, in this case, CD19. And we have what's called gating to look at specific cell populations. So our first plot here is just sort of gives you an overall view of the basic cell populations, lymphs, monocytes, granulocytes. We call this the blast gate, which in this case, they are blasts, but it's not always blasts that fall in the so-called blast gate. And we look at these on a CD45 versus something called side scatter, which is not a fluorescent antibody. This is more of the inherent properties of the cells themselves. So the more cytoplasmic granules or vacuoles you have, the higher you'll go to the right on the x-axis. So we got our basic cell populations here. In the red is the CD45 DEM gate. So about 10 to the third is DEM on our particular flow panels. And then, so we've honed in on the blast population here. And I have some key plots to show you. And all of these subsequent plots look at mainly the blasts. With the gating here on the blasts, we also have on the plots what's called quadrant gating. So the way it works is that generally anything to the right of the line is considered positive for that antibody. So these cells here would be considered positive for CD34. And anything up here would be considered positive for CD19, and anything here would be dual positive for both antibodies. And then anything in the left lower quadrant would be dual negative. So it's a little more nuanced than that. You have to know where to draw the quadrant lines, but this will give you the basic idea of what we're looking at here. So for this particular blast population in the red, there is a partial expression of CD34. It's negative for CD19, a B cell marker. It is showing DEM CD45 expressions. So CD45 is a pan hematopoietic marker that's expressed on most hematopoietic malignancies. CD34 is a stem cell marker that is seen in probably, I dare say, most acute leukemias. And then CD117 here, it is showing some positivity for that as well, which is generally considered a myeloid marker. And then down here we have partial expression of CD7, which is generally a T cell marker, but may be aberrantly expressed in some myeloid leukemias. Same thing for CD56, generally a T or NK cell marker. We have partial expression here. And what's really interesting about this is that there's really bright expression of CD41, which is a megakaryocytic marker. And it's so high, above 10 to the 5th, that it's almost off the chart. So very bright CD41 expression, strongly positive. So, so this was the final diagnosis on the flow cytometry report, positive for circulating blasts, about 30% of the total cells on the smear. And my comment was that the blast showed some morphologic and immunophenotypic features of megakaryoid blasts. By manual differential, the blasts comprised approximately 30% of cells, and it was a similar percentage on flow cytometry. Given that the patient has Down syndrome or trisomy 21, these findings are consistent with a disorder called transient abnormal myelopoiesis, and close clinical follow-up is recommended. So indeed they did do that, and this is a series of CBCs with differentials performed over about 2 weeks, going from left to right. And you can see here that the total leukocyte count went down in the course of that time from about 38,000 to normal range. The platelet count also normalized, going from above 1 million to a normal count of 470. And the differential, originally we had noted some, immature granulocytes like myelocytes and metamyelocytes on the smear, and of real importance here is the blast count, which when I first looked at it was thought to be 30%, and over the series of about 2 weeks, this count subsequently came down, and these blasts actually disappeared. So, so this is why this disorder is called transient. So transient abnormal myelopoiesis is the most common leukemia in neonates. Clinically apparent TAM is seen in about 10% of Down syndrome patients. There is also a clinically silent TAM, which I find interesting. But this one was clinically apparent, and with the clinically apparent cases, they can range from an asymptomatic incidental finding to life-threatening disease that involves the liver and the spleen and causes things like pleural and pericardial effusion, skin rashes. Most patients present within the first 7 days of life, so this can be quite frightening to caregivers, to clinicians, even as pathologists. Something that looks like acute leukemia in a newborn. It is possible for newborns to have acute leukemia, to be born with acute leukemia, or develop acute leukemia in the neonatal period. In this case, this is a disorder that mimics acute leukemia. And what's really interesting is that the vast majority of cases resolve within a few months' time without treatment, which makes some clinicians nervous. We are fortunate here that our clinicians are very comfortable with watching and waiting. A minority of cases go on to develop what is called myeloid leukemia of Down syndrome, which is essentially a form of AML. It used to be called that. TAM on smear morphology, will show increased blasts, in some cases, maybe very extreme leukocytosis greater than 100,000. And anemia is uncommon, which I find interesting. And the platelet count can be anything, normal, reduced, or increased, as in this case. And the peripheral blood, you should see circulating blasts. And another thing that's interesting about this is that the blasts can range from sort of a generic myeloblast morphology, perhaps like this one here, to megakaryoblast morphology, like these cells here, which have these sort of cytoplasmic blebs on them. And you have to know what you're looking for. This, in my opinion, could be easily overlooked if you're not thinking about it, because the megakaryoblast, in my experience, are not always so apparent on the smear. They can be sort of smaller in size than other blasts that we typically see, and the chromatin may not be so fine or immature appearing as other kinds of leukemias that we see, and it can almost look sort of lymphoid. And the little cytoplasmic blebs, they may or may not preserve very well with your smear preparation. And like you can see this one here, this bleb got smudged right here. So, anytime I see anything that looks like potentially blasts on a peripheral smear in a newborn, I go and look in the chart to see if it's a Down syndrome patient. And it, in some cases, they may not even know that the patient has Down syndrome. So, you may have to, recommend testing for that. The underlying mutation in this disorder is a mutation in the GATA1 gene located on the X chromosome, and it encodes a zinc finger-containing protein that's essential for normal erythropoiesis and megakaryopoiesis. And so when it's mutated, it causes a maturation arrest that leads to the production of megakaryoplasts. Myeloid leukemia of Down syndrome is sort of a cousin of TAM, and the patients are a little bit older with the median age of onset of 1.6 years. It may be preceded by TAM. It can also be preceded by a myelodysplastic syndrome phase of pancytopenia that can last for several months. Again, the blasts often express megakaryocytic markers, and the box count may not reach the conventional 20% that we generally expect in AML. In the bone marrow, reticulum fibrosis is frequent. And so in addition to GATA1, typically there will be other mutated genes which will help to make the diagnosis. All right, moving on. Do we have any questions yet? Oh, okay, good. Case number 2 is a 4-year-old male who presented for evaluation for normocytic anemia. He had a prior history of recurrent skin abscesses with staph infection and ongoing immunodeficiency evaluation, which I don't really honestly think ended up being relevant to the diagnosis that we rendered here, unless, the diagnosis actually was a source of the immunodeficiency. But he was in the process of being worked up, noted to have mild hepatosplenomegaly on imaging. Let's see. And on his CBCs, you could see, so we have some anemia. The MCV is a little bit elevated here, but mostly normocytic. The platelet counts varied from normal to mildly decreased. What was really interesting is that the monocyte count, the percentage was persistently increased. There were some immature grands noted at some points in time. Looking at the absolute counts here, you can see for monocytes, so this is times 10 to the third. So this is actually 5,200, 3,400. All of these are persistently elevated above 1,000. And this is over a period of about 3 or 4 months going from left to right. He initially was evaluated at this point in time for the anemia and was originally treated somewhere else, and then came to our center and we evaluated him at this point in time. On peripheral smear morphology, you could see a number of cells of monocytic lineage. And so these here are more mature, but they have very abnormal nuclear contours. This one here, not really convoluted to the degree of mature monocyte, maybe a little indented here. It's questionable, how mature the chromatin is, and maybe slightly immature. I don't know that it quite meets, the pro-monocyte, threshold for immaturity. But they did a bone marrow on him, and there were more monocytic appearing cells in different stages. So some are more mature, with a lot of convolution and sort of in abnormal and bizarre shapes for monocytes generally. And then some were more immature with finer chromatin in keeping with a blast and nucleoli. And maybe, a little irregular in the nuclear contours You can see a little bit of indenting or notching here, but there aren't deep convolutions. This is a nice monoblast here with fine chromatin, prominent nucleoli, and you can see that these cells have the blue-gray cytoplasm that is typical of a monocyte. So you can kind of get the feel from looking at them that they are of monocytic lineage. So there were a number of these cells on the smears, and the feathered edge of the smear, I found some additional findings, a number of eosinophils here. Interestingly, the granulocytes sort of collected out in the periphery, so they're not well preserved here. But what's really interesting is that there were a number of small, very small and hypolobated megakaryocytes, and some of them had, widely spaced separate nuclear lobes that you could honestly call these dysplastic. I believe they meet the definition of dysplastic, with widely spaced separate nuclear lobes, just two of them. Sometimes a dysplastic megakaryocyte could have three separate nuclear lobes. So there were a number of these scattered around. This is an H&E of the core biopsy. You can see at low power, it's very cellular. There's almost no fat. There might be one little, fat cell right here. Here to higher power, I think you can appreciate that there's trilineage hematopoiesis. We have some erythroids. I see some sort of small megakaryocytes here. Go to higher power, you can see things a little better. So you can see these small megakaryocytes. Again, the eosinophils, the erythroids, the dark round, sort of glassy looking nuclei, and also a number of, immature mononuclear cells sort of scattered around. It's kind of hard to tell what lineage they belong to. And on immunohistochemical staining with CD34, it did show a number of positive cells in keeping with blasts, sort of scattered around. There are also some sort of non-specific staining in the background and cross-reactivity with vessels. CD34 is also a vessel marker. So that's a good internal control, showing positive staining there. This is CD61, which is another megakaryocytic marker in addition to CD41. And this was performed to be able to better see the megakaryocytes and pick them out from the background. And so we have these cells scattered around that are small and hypolobated, in keeping with dysplastic megakaryocytes. There were quite a few of them in this case. Some ancillary studies were sent, including, conventional cytogenetics for karyotype, and it showed, in addition to, male chromosomes XY, there was also monosomy 7, loss of chromosome 7 in all 20 cells. And then a next generation sequencing panel for myeloid-associated mutations was performed, and it showed pathogenic mutations in ASXL1 and KRAS. Now, ASXL1 is a myeloid-associated mutation that is seen in a number of different myeloid malignancies. Is not terribly specific, but KRAS in this context is diagnostic. You do see it in other malignancies, but it's important for this particular diagnosis. And of note, this KRAS mutation is noted to be somatic. The allele frequency is only about 29%. If it had been around 45 or 50%, we would be questioning whether it was a germline mutation. But it's not. They also found a variant of unknown significance in ETV6. When you see pathogenic mutations, ETB6, you can see that in, a variety of myeloid and lymphoid leukemias, but in this case, this particular mutation, ETB6, was of uncertain significance. The final diagnosis was a hypercellular marrow greater than 95% involved by juvenile myelomonocytic leukemia with 11% blasts and promonocytes. So monoblasts and promonocytes are the blasts and blast equivalents that are of interest in this particular disorder. So what is JMML? It is a myeloproliferative neoplasm of early childhood with both granulocytosis and, more importantly, monocytosis. So the monocytosis is necessary to diagnose it. Usually you see granulocytosis, but not necessarily. About 25% of cases have a germline mutation. You can see it in patients with neurofibromatosis type 1, Noonan syndrome, or something called CBL syndrome with any of these mutations. And these mutations, they involve the RAS signaling pathway that's involved in cell growth and proliferation and survival. And so here, there are a variety of cell structures or proteins that these genes encode, NF1, NRAS, KRAS, PTP, and 11, CBL. So this is the current WHO criteria. You have to have a peripheral blood monocyte count above 1,000, and it's generally understood that this needs to be persistent. It's not going to be just a blip in time, because you can see that as a reactive process, particularly in children. The blast and blast equivalent count, or monoblasts and promonocytes, should be less than 20% in the peripheral blood and bone marrow. Otherwise, you call it acute myeloid leukemia. There should be clinical evidence of organ infiltration. Most commonly, you will see splenomegaly. And you should see no BCR-ABL, or Philadelphia chromosome on karyotype, or a KMT2A rearrangement. And this is included specifically because AML with this particular rearrangement typically has monocytic differentiation. You're required generally to have one of the genetic criteria, which is one of the following mutations: somatic mutation in PTP and 11, KRAS or NRAS, or somatic or germline mutations of NF1 or CBL, with some caveats. And then there are also, and this is new, I believe, to the current version of the WHO, other less commonly reported mutations such as ALK and PDGFR beta RAS1 that you can see in JMML. If you don't meet the genetic criteria, then you have to meet two of the other criteria, which is increased hemoglobin F for H. You can run hemoglobin electrophoresis for that. Basically, immature granulocytes and nucleated reds or erythroid precursors on your peripheral smear. Thrombocytopenia, the decreased number of MIGs in the bone marrow, and they may or may not show dysplastic features. And what's interesting is, in our case, the megakaryocytes were very dysplastic. And actually, the patient had a bone marrow initially when they were worked up at another institution, and they misclassified the disease as childhood myelodysplastic syndrome because they didn't notice the monocytosis or have the data tracking the monocytosis over a period of time, and they didn't have all of the molecular testing and other ancillary testing back to demonstrate that it all fits with JMML. This last criterion, hypersensitivity to GM-CSF, this is more of a research-based assay. I'm not aware of this being generally available clinically. And here's another example of JMML with some really nice, monoblasts and promonocytes of fine chromatin. So maybe this is a little indented. So the way I think of it is monoblasts don't have any indentation or convolution, but they have fine chromatin, may have nucleoli. The promonocytes are basically the same, except they can be either a little bit indented, or they can have a single cleft going all the way through, like right here. But they should not otherwise be deeply convoluted like this right here. Otherwise, you would classify the cell as some sort of mature monocyte or perhaps an immature monocyte. So there, monocyte morphology is very much in the eye of the beholder, and pathologists can disagree on this. And anytime there's a monocytic leukemia and we try to count the monoblasts and promonocytes, we sort of hand the case around and get an opinion for, from all of our colleagues. And, pathologists can legitimately, disagree on the blast count in these cases. That's not uncommon for this disease, as well as similar diseases like chronic myelomonocytic leukemia in adults, and the AMLs with monocytic differentiation. Case number 3 is a 15-year-old male who had fevers, back
Dr.
pain.
Christine, sorry.
Yeah, go ahead.
Okay, I think Dr. Nimera has a question before we proceed.
Sure, go ahead. What's the question?
Dr. Nimera, if you
Or you can put it in the chat box. I have my chat box up now.
I think we can do that. Okay. Apologies. Proceed.
You want me to proceed?
I think so.
Okay. I can take questions at the end as well. It's not a problem. All right. Let's see. Case number 3 is a 15-year-old male who had fevers, back pain, and multifocal lymphadenopathy. The CBC and differential were within normal limits. That lymphadenopathy included enlarged inguinal lymph nodes, and a left inguinal lymph node was excised for further evaluation. This is a low power H&E view. It is a little bit fragmented. They didn't really get the capsule in this, but you can kind of get a sense that the normal architecture of the lymph node is effaced by a process that is a little bit paler in color than perhaps a normal lymph node would be expected to appear as, and good intermediate power and sort of this, diffuse infiltrative cells that are, small to intermediate sized, and have abundant pink cytoplasm. You can go to higher power. You can kind of appreciate that there's a few smaller lymphs sort of scattered in the background, as well as a few plasma cells. But mainly it's this infiltrative cells, and they almost sort of look like histiocytes. So some immunohistochemical stains were performed to further evaluate this lymph node. And what it showed was that the cells of interest were negative for CD3, our basic T cell marker. You see it staining background small T cells, which are reactive. And then on the right, CD20, our B cell marker, is negative on the cells of interest as well, and it's staining small B cells in the background that are benign. And on the lower left, the cells of interest are strongly and diffusely staining with CD43, which is a T cell marker. And on the lower right, it's staining very nicely, strong membranous and Golgi staining for CD30. So you see membranous staining, and you can see these dot-like inclusions in the cells staining, and some of them which is the Golgi region. And this staining pattern, is characteristically associated with Hodgkin lymphoma, but that is not actually what this entity is. The cells of interest were also positive for T cell markers CD2, CD7, and CD56, which are not shown here. They were negative for EBV, by in situ hybridization, which is a little bit different technique from immunohistochemistry. And on the left, I had a picture of ALK1 from this case, and at the last minute, I decided the stain wasn't a really great technical quality, and I didn't really want to show it. So I pulled this as an example from pathologyoutlines.com, and it's just very nice, both nuclear and cytoplasmic staining for ALK1, which is diagnostic in this particular case. Some ancillary studies were performed, including FISH, fluorescence in situ hybridization, and what it showed was that it was positive for ALK rearrangement in more than half of the cells, 55%. Now, this won't tell you the gene partner for the ALK, and unfortunately, the cytogenetics panel, the karyotype, it didn't really grow, so it didn't really clarify any further what that rearrangement was. All we know that is that it involves ALK, but based upon the staining pattern, nuclear and cytoplasmic, we expect or believe that it's a translocation 2-5, which I'll get to here in a second. So this was signed out as ALK positive anaplastic large cell lymphoma. And in this particular case, the morphologic pattern was consistent with the small cell variant of ALCL. And I'll explain a little bit further in a second what that means. So anaplastic large cell lymphoma has two broad categories, basically ALK positive and ALK negative. And the ALK positive are predominantly seen in pediatrics and young adults with a male predominance. The ALK negatives tend to be seen in older adults, and they don't do as well as the ALK positive cases. Though interestingly, we've had a couple of ALK negative ALCLs recently in the form of a post-transplant lymphoproliferative disorder. So those were very challenging cases to diagnose. But generally, ALCL will be ALK positive in children. Both lymph nodes and extranodal sites may be involved. Bone marrow is involved in a small percentage of cases. The majority of patients present with advanced disease and what are called B symptoms, which are classically associated with Hodgkin lymphoma, but can be seen in other lymphomas as well. And it involves symptoms like fever, extreme weight loss, drenching night sweats. This lymphoma is curable with aggressive chemotherapy, but relapses are common. On morphology, you can see partial to complete effacement of the nodal architecture. And if you catch it early, it will involve the paracortical areas and the sinuses initially. And this can actually be very easy to miss in the sinuses, particularly if the cells are not that big. They can kind of just look like histiocytes, like in our case. So you have to sort of have an index of suspicion for it. In the classic ALCL cases, you see these pleomorphic, bizarre nuclei with prominent nucleoli called hallmark cells. They can also be described as horseshoe shape, and I have an example here on the next slide. There are a number of variants. This list is not all inclusive, but small cell variant is what we have. There's also a lymphohistiocytic variant, which is similar to small cell, but with a number of histiocytes in the background. There's a Hodgkin-like variant. So anytime we have anything that looks like Hodgkin lymphoma, typically we throw on an ALK1 stain just to make sure that it's not really ALCL. The immunophenotype, the diagnostic stains are the CD30 and the ALK1 positivity. And there should be some combination of T cell markers present to establish a T cell lineage. So CD2, CD5, and CD4 are common. They're generally negative for CD3. Occasionally they're positive. Commonly positive for CD43, as in our case. And if it's, negative for surface T cell markers, you can look at cytotoxic proteins like TRA1, granzyme B, and perforin. And one of the cases we had recently, we actually had to do that to substantiate the T cell lineage. And there's actually, to make matters even more confusing, there is a thing called a null phenotype of ALCL, in which it's negative for all T cell markers, and so it can be very challenging to prove that it's ALCL, of T cell lineage. On genetics, the most common translocation 2-5, where the ALK gene is rearranged to the NPM1 gene, causing upregulation of the ALK gene. And what's interesting is, depending upon the particular translocation you have, it can have different staining patterns of the ALK1. And so this translocation is expected to have nuclear and cytoplasmic staining of ALK1, as we had in this case. There are more than 20 different partner genes for ALK1, and they predominantly show just cytoplasmic positivity for ALK, and not nuclear positivity. This is another example of ALCL, and this one actually has some nice hallmark cells, or wreath-like or horseshoe-shaped nuclei that you can see here. So there's a variety of cell sizes. Some are larger and some are smaller. And on the top left is more of a lower power view with some cohesive sheets of cells that to me look like they may be infiltrating sinuses. And so this is the type of thing that we look for in subtle cases that you don't want to miss. Okay. Make sure, any questions about that? Okay. Last case. This one is interesting too. This is a 15-year-old male who had cervical lymphadenopathy for a few months, no significant past medical history. CBC and differential were within normal limits. A cervical lymph node was excised for further evaluation. This is the low power view of the lymph node. You can see the capsule here. We don't really have a sinus left. It might be a little challenging to ascertain at first, but basically this is not normal nodal architecture. There is sort of this vague nodularity at low power, and then these sort of patchy pink areas that are very characteristic of this particular disorder. And sometimes this sort of pattern is referred to as a moth-eaten appearance. I don't know if you have moths where you live, but yeah, here, there are insects that, like if you get them in your storage, and they can eat holes through your clothes and leave all, holes everywhere, and people will put mothballs, in their storage, in trunks of clothing, to keep the moths away. And they stink really bad. So this is sort of referred to as a moth-eaten appearance. And so the low power view is really key to, thinking about this particular entity. And go to a little bit higher power, you might appreciate it a little bit better, the nodularity and the moth-eaten appearance. At high power, within the nodules, there are these scattered larger cells that are multinucleated and have sort of what we call vesicular chromatin, or I like to call it bubbly. To me, it looks bubbly. And there are sort of these, small, smaller looking nucleoli, multiple nucleoli in them. So not quite like Reed-Sternberg cells, but not normal components of a germinal center, let's say. And so immunohistochemical stains were performed to further evaluate this lymph node. And so on the left, you can see CD3 staining the background T cells, and the stain is a bit dark and kind of masks, what's going on here. But on the right, a CD20 is staining the B cells, and it's bringing out that nodularity. And so what it's showing is that the nodules are composed mainly of small B cells. And you can see it here on the lower right, the CD20 is staining mostly small B cells, but it's also staining the larger cells of interest. And these cells of interest are negative for CD30. You can see one here, and negative for CD15. You see one here, one here. So, these two markers, are what we are part of the workup for classical Hodgkin lymphoma. On the top left, we have CD45, which is basically staining everything, both the small cells and the larger cells. So the cells of interest are positive for CD45 and CD20, negative for 30 and 15. In this view, again, we have CD20 and staining the larger cells. And then we have three different B cell nuclear transcription factors, PAX5, OCT2, and BOB1. The stain is a little messy with a lot of background, but what you can see here is that it's staining the larger cells fairly strongly with these transcription factors. So there's strong staining on all of the B cell markers that were applied to the tissue. These are CD21 and CD23, which are markers for follicular dendritic cell meshworks, which are these networks of cells within germinal centers, and they sort of roughly map the outline of the lymph node and can give you a sense of the overall architecture. At a normal, benign reactive lymph node, generally these meshworks will be small and round and well defined, perhaps more like this right here. But in some lymphomas, the architecture of the dendritic cell meshworks is altered, and this can be a clue in making the diagnosis. And so this one had very beautiful expanded and branching, interconnecting follicular dendritic cell meshworks, which are very, characteristic of this particular entity. It's not specific for this. You can see it, in other lymphomas, but this was a key in helping to make this diagnosis. CD57 and PD1. These are markers that you see on what we call T follicular helper cells. And in this particular entity, you see these rosettes of T cells, which are positive for T follicular helper cell markers like CD57 and PD1. And so you have a ring of these positive cells surrounding this large cell here, and a ring of positive PD1 cells surrounding this cell here. There's also a rosette here, a rosette here. And so this is another helpful feature in making this diagnosis. So the diagnosis is nodular lymphocyte predominant Hodgkin lymphoma. This is a different entity from classical Hodgkin lymphoma, which I presented last year. It is approximately 5 to 10% of all Hodgkin lymphoma cases. The male predominance, the median age is around 30. but it's not uncommon in pediatrics. We see it occasionally. Peripheral lymph nodes are generally involved, like cervical, axillary, or inguinal. Occasionally mesenteric lymph nodes can be involved, and it's usually localized disease. It has an excellent prognosis. The overall survival rate of more than 90%. And my understanding is that they don't all necessarily even need to be treated, particularly in pediatrics. It is a B-cell neoplasm characterized by these scattered clonal cells, so those large cells that I pointed out to you. The preferred terminology currently is LP cells, which stands for lymphocyte predominant cells. Originally, these were called LNH cells, or lymphocytic and histiocytic cells. They've had a number of names through the years. And there's a slang term for it called popcorn cells. I don't know if you've ever heard of that. I don't know if you eat popcorn. In our culture, you know, popcorn is a snack where you take dried corn kernels and you heat it, and it forms popcorn. And so the cells sort of, you know, resemble popcorn on H&E. But anyway, you see these scattered clonal cells in a background of reactive lymphocytes and histiocytes, and a mostly nodular pattern, sometimes a diffuse growth pattern. The LP cells have a large nuclei with lobular contours, variably prominent nucleoli. They have a germinal center B cell phenotype. So the key here is that every B cell marker you throw on it generally should strongly stain these cells. If it does not, you have to consider whether you have the right diagnosis, or is it really classical Hodgkin, because classical Hodgkin does not strongly stain all B cell markers. And so that is a key difference. Classical Hodgkin has an interrupted B cell program, whereas nodular lymphocyte predominant Hodgkin does not, and should generally stain strongly with every B cell marker you throw on it. And if we get cases where we're not sure if it's classical Hodgkin or nodular lymphocyte predominant Hodgkin, we will start throwing every B cell marker we find, and it could be 4 or 5 B cell markers or more. We don't generally need that many to diagnose a B cell lymphoma. And, you know, often in the differential of nodular lymphocyte predominant Hodgkin is lymphocyte-rich classical Hodgkin lymphoma, which can look very similar. And so those follicular dendritic cell meshworks that I showed you, those are important because in lymphocyte-rich classical Hodgkin, you will not see that pattern. Instead, you'll have these small, contracted, round follicular dendritic cell meshworks. And so that difference can be helpful in differentiating the two lymphomas. And nodular lymphocyte predominant Hodgkin lymphoma, in addition to strong B cell marker expression, it will also be positive for BCL6, which is a germinal center B cell marker. And then in the background, generally you get mostly small B cells, and then a smaller component of T cells, which have the T follicular helper cell phenotype with markers like CD4, PD1, and CD57. There are other markers as well that you can try. There are some, you know, variants of this lymphoma that have more T cells than B cells, which invokes other differentials. And I find this honestly to be a tricky diagnosis sometimes. You know, you can get these diffuse patterns that resemble T cell histiocyte-rich large B cell lymphoma. And to make, you know, matters more confusing, this particular lymphoma can transform to large B cell lymphomas, including the T cell histiocyte-rich large B cell lymphoma, which has these scattered large B cells and a background of, you know, lots of T cells and histiocytes. And so these can be very challenging cases, and these are cases that sometimes we might choose to send in consultation to an expert lymphoma pathologist. There is also, an association of this particular lymphoma, NLP lymphoma, with a lesion called progressive transformation of germinal centers, which I have not shown examples of here, but basically this is thought maybe to be a pre-neoplastic lesion. It's not entirely clear, but generally you see it in like adolescent males, and it'll be in typically like a cervical lymph node, and it will involve a few follicles. You get these big expanded follicles that kind of resemble follicular lymphoma, but are not follicular lymphoma. So this is a very interesting lymphoma, and I think sometimes a little bit challenging to diagnose. Here's another example of this particular lymphoma. On the top left, a nice low power view where you can see the nodularity. And top right, more of an intermediate power view with these scattered pink cells, which are the histiocytes, and this is very characteristic. And you can see the same thing here, a little bit higher power. And I mean, I've seen pathologists, look at these at low power, and I've actually learned to do this myself. You can look at it at low power and instantly recognize this is probably NLP Hodgkin lymphoma. You still have to examine it carefully and do due diligence and do all of your stains and rule out relevant differentials, which can be 0 to 7 done in some cases. But generally, when you look at these, you get a sense at low power that this is probably nodular lymphocyte predominant Hodgkin lymphoma. And a nice example of an LP cell on the lower right, a large cell that's multilobated with vesicular chromatin and multiple nucleoli. And with that, that concludes my presentation, and I will entertain any questions. Pull up the chat box,
Thank you very much, Dr. Christina. Right now, we don't have any questions, but dear participants, if you have any questions, any reflections, please.
Well, there's one question that just says NLPHL question mark. I'm not sure what exactly, maybe they were guessing the lymphoma before I got to the diagnosis. If you did, then good for you. I was guessing, yeah. See, I told you, you can see at low power and think, yes, it's NLP.
Any other comment, question, or reflection from other participants?
One message. You're quite welcome. All those that are thanking me. I'm very happy to present to you today. I appreciate the invite, and feel free to reach out to me via my email address. And of note, we do take consultations here for pediatric hematopoietic disorders. So feel free to reach out to us if we could be of help to you.
Okay, thank you, Dr. Christina. Dr. Chain, Dr. Rahel, if you have any additional comments or reflections before we wind up.
Nope, just thank you all for joining and staying for this long. I know it's been 3 hours of lectures.
Yeah, that's okay.
Yeah, it's been great. Thank you, Dr. Christine.
St. Paul Hospital. Where is St. Paul Hospital? There's
It's
more than
another.
one.
It's
Is that in
another
your,
in Addis Ababa.
is that in your country? Because we have St.
Yes.
Paul here in the States too.
Oh, it's in
Yeah,
Addis Ababa. There are 2 medical schools, public medical schools here in Addis, and St. Paul is one of them. The other one is Addis Ababa University, where Dr. Rahel is from.
How many medical schools do you have in your country?
Wow, quite a number of them, like at least 13.
Yeah.
And this including this is only the governmental or public medical schools. There are also a number of private schools, but their numbers are limited.
St. Paul's, very good. Adi Sampala. This is my email address. When I first typed it here, it capitalized my first name, which I think our email addresses are case sensitive. I'm not sure. Sonia might know. But yeah, just keep it all lowercase. Christina.Brannick@nationwidechildrens.org. But you know, you could probably find other ways to contact us if need be. So we're on the internet. You can contact our department if you are interested in consultation.
Okay. I think it's about time. Dr. Rahel, Dr. Chain, and Dr. Christina, thank you very much for your presence here, and all of our participants. Thank you very much for attending. Thank you for staying with us for the last 3 hours. Please also meet us tomorrow for the next series of pathology lectures. Dr. Chain and other participants. Dr. Diana will also be here again. With that, I think we can wind up today's session. Good evening and good afternoon, everyone.
Thank you. Bye.
Goodbye.
Thanks so much. Bye-bye.
Bye, everyone.